Ace, are you around? Ace, please, if you could share your screen.
Okay, I share it now.
So, good afternoon, everyone. Welcome to our academic activity for today. We'll have 5 lectures. We'll start with anatomy and pathophysiology of aortic valve disease. Dr. Ace Sawat. Then aortic valve replacement. After that, stented and stentless aortic valve replacement and root replacement. Fourth lecture will be outcomes of aortic valve replacement, and finally, case discussion with Dr. Trabzoni at 3 p.m. inshallah. So if you are ready, Ace, you can start.
Okay, do you hear my voice?
Yes.
Do you see the slides?
Yeah, we can see your slide.
Okay. Good afternoon, everyone. Today I will talk about the aortic valve disease. I will talk about the anatomy and the pathophysiology of the aortic valves. First of all, we will start by the anatomy of the aortic valve. The aortic valve is the last of 4 cardiac valves through which the blood is pumped before it goes to the rest of the body. It's the left ventricular outflow tract from the aorta, and its main function is to prevent backward blood flow from the aorta to the left ventricle while allowing the blood to flow forward during systole with minimal resistance. As we see here, this is the surgical view. When you open the heart, when you do the sternotomy, we will see directly the right atrium in front of us, and above the pulmonary trunk, and at the left side is the aorta, and at the surgeon side, you see the right atrium. The aortic root is the anatomic segments between the left ventricle and the ascending aorta, and it contains the aortic valve. And the other anatomical elements which function as ionets. The aortic root has several anatomical components. These components are the subcommissural triangles aortic annulus, and aortic cusps, and aortic sinuses or sinuses of Valsalva, and sinotubular junction. As we see here, there's a subcut of the at the sinotubular junctions, showing us the aortic valve from above. As we see, here's the aortic valve cusp, and as we see, here's the left and right coronary sinuses, which are originating the left and main coronary artery, and the right main coronary artery will be discussed later on. So we will start the subcommissural triangles are the part of the left ventricle's outflow tract, and the subcommissural triangles, the non-coronary aortic cusps, are fibrous extension of the interventricular fibrous body and membranous septum, whereas the subcommissural triangle beneath the left and the right aortic cusp is an extension of muscular interventricular septum. The aortic annulus is a fibrous structure with a scallop shape attached to the aortic valve to the left ventricle. It's attached directly to the myocardium in approximately 45% of its circumference, and to fibrous structure in the remaining 55%. The diameter of the aortic annulus is 10% to 20% larger than the diameter of the sinotubular junction of the aortic root in young patients. As number of elastic fibers in the arterial wall decreases with the age, the sinotubular junction dilates, and its diameter tends to become equal to that of the aortic annulus in older patients. With dilatation of the aortic annulus, the subcommissural triangles of the non-coronary cusp tend to become more obtuse as a crescentic shape with aortic annulus along its fibrous insertion, and which may lead to AI. As we see here, there's the heart is open, and we see the trigone. We see the left coronary cusp attached to the fibrous, the fibrous tissues of the mitral leaflets, which is called the trigone. Here's the upper view of the heart, of the four valve chamber of the heart. During the diastole, there is a closure of the pulmonary valve and aortic valve and opening of the mitral and tricuspid valve. And during the systole, there's a closure of the tricuspid and mitral and opening of the aortic and pulmonary valve. The cusps, the normal aortic valve has 3 cusps. Each cusp has a semilunar shape and has a base and free margin. The base is attached to the aortic annulus in a crescentic fashion. The point at which free margin of cusp joins its base is the commissures, and the ridge of the aortic wall that lies immediately above the commissure is the sinotubular junction. At the midpoint of each free edge is a vibronodulus aranti. On either sides of the nodules is extremely thin. The free margin of the aortic cusp extends from one of its commissure to other. The length of the free margin of the aortic cusp is approximately 1.5 times the length of its base. The 3 aortic cusps often have different sizes in a person, and the right and the non-coronary cusp are usually larger than the left coronary cusp. The same cusp may have different sizes in individuals with same body surface area. But during diastole, the free margin and part of the body of the 3 cusps touch each other approximately in the center of the aortic root to see the aortic orifice. Those average the length of the free margins of the 3 aortic cusps must exceed the diameters of sinotubular junction to allow cusp to cooperate centrally and render the aortic valve competent. Each cusp or the aortic leaflet display 3 layers of connective tissues. These layers are the ventriculosa on the ventricular side and the fibrosa or arteriosa on the aortic side, and the spongiosa between them. The fibrosa is mainly composed of collagen fibers, while the ventriculosa mostly consistent of elastic fibers. Between these two layers, the spongiosa is component of mucopolysaccharide gel-like substance that facilitate the motion of the ventriculosa and the fibrosa. If pathological process causes shortening of the length of the free margin of the cusps, or if the sinotubular junction dilate, the cusps cannot coabate centrally, resulting in AI. If the length of a free margin is elongated and cusp prolapses, and depending on the degree of the prolapse, there will be aortic insufficiency. As we see here, there's imaging showing the aortic valve when it's opening, showing here's the right coronary artery and the left coronary artery coming from the left and right coronary sinuses. And you see here the non-coronary cusps attaching to the tricusp and mitral valve and left and right side. As we see here, the cusps, the cusp is dividing to four sides. This is coapting surface, and here's we call in the mid we call it belly, and here's the hinge and the attachment of the commissures. Each cusp it's called annulus. As we see here, these three three cusps, the left and right are fused together, fused leaflets, and then coronary is not fused. So when they are opening as a bicuspid valve. This is a congenital and the left at the right side we see the anterior posterior leaflets without any other leaflets. This is called bicuspid aortic valve. The aortic sinuses or sinuses of Valsalva, the spaces contained between the aortic annulus and the sinotubular junction are the aortic sinuses. There are three cusps and three sinuses: left cusp and sinus, and right cusp and sinus, and non-coronary cusp and sinus. The left main coronary artery arises from the left aortic sinuses, and the right coronary artery arises from the right aortic sinus. There are three sinuses of the aortic valve, each related to the valve's corresponding cusps. Each sinus is divided into three areas at central part and two adjacent parts, which are named according to the valve cusp they adjoin. The non-coronary sinus is also referred to as the posterior aortic sinus. The aortic sinuses facilitate closure of the aortic valve by creating eddies and currents between the cusp and arterial wall. They also prevent the cusp from colluding the coronary artery orifices during systole, thus guaranteeing myocardial perfusion during the entire cardiac cycle. The right coronary sinus, entire right coronary sinus lies adjacent to the RVOT. Central part lies adjacent to the crista supraventricularis, and the left part is adjacent to the area of the RVOT in the angle between the crista supraventricularis and the pulmonary valve. Posterior non-coronary part of the right coronary sinus is related to the area of the right ventricle posterior inferior to the crista supraventricularis. Inferiorly, in the entire right coronary sinus is related to interventricular septum. The muscular septum lies under the central and left parts, while either membranous or muscular septum may lies under the posterior part of the right coronary sinus. The non-coronary sinus, the atrial chamber with the intervening atrial septum lies adjacent to the coronary sinuses. Right and central parts of the non-coronary sinus are related to the right atrium and interatrial septum. Left part is related to the left atrium. Inferiorly, the right part, like the posterior part of the right coronary sinus, may be related either to the membranous or muscular septum, depending on the size of the membranous septum. However, beneath central part of the non-coronary sinus, the membranous septum is consistent structure, and the left part of the non-coronary sinus insert into the posterior anterior mitral leaflets, as we see it in the previous images. Left coronary sinus, posterior part of the left coronary, it's related to the left atrium posteriorly and to the anterior mitral leaflets inferiorly. Central part of the left aortic sinus is the only part of the aortic root that is not related to cardiac chamber. It's adjacent to the pericardium only. Right part of the left coronary sinuses lies adjacent to the pulmonary trunk. At the level of the left pulmonary sinus, inferior to it lies the muscular interventricular septum. The aortic root of young individual is elastic and very compliant. It expands and it contracts during cardiac cycle. The normal aortic root has fairly consistent shape and sizes with the cusps and aortic annulus. The aortic sinuses and the sinotubular junctions are somewhat interdependent. Those large cusps have proportionally large annulus, sinus, and sinotubular junction. Here we see the etiologies of the aortic valve disease, but the primarily it could be congenital malformation by cusp aortic valve, inflammatory disease, rheumatic or lupus erythematosus, degenerative diseases, as you see it in the elderly patient, valve sclerosis, calcific stenosis, bacterial endocarditis, trauma, or tumors. Secondary aortic valve disease are aortic annulus, ectasia, or aortic aneurysm, or aortic dissection causing acute regurgitation. Aortic valve lesion, according to the level of the valve, at the level of annulus, either dilatation or abscess or calcification. At the level of the leaflet, distension of the leaflet, tear of the leaflet, perforation or vegetation, or thickening or calcification. At the level of commissures, ruptures of the commissures, fusion or calcification. At the level of the aorta itself, either dilatation or aneurysm, dissection or calcification. Now we will talk about the aortic stenosis. Aortic stenosis, it's narrowing of the aortic valve. That's not allowing the blood to flow freely from the left ventricle to the aorta during aortic stenosis. So the epidemiology and etiology isolated aortic stenosis is more common in men than in women and is found in 2% of people 65 years of age and older. The most common causes of aortic stenosis include age-related calcific degeneration by cusp aortic valve and rheumatic aortic valve. The distribution of these causes varies across age groups and geographic region. Age-related degenerative is the most common cause of the aortic stenosis patient older than 70%. In contrast, bicusp aortic valve calcification account for most surgical cases in a patient younger than 70 years. As we see here, the valvular aortic stenosis has three principal, I will say, principal causes, either congenital bicusp aortic valve with superimposed calcification, as we see in image B, and the calcification of normal trileaflet valve, as we see in the image D, and rheumatic disease, as we see in the image C, and in the image A, we see the normal aortic valve. So fixed obstruction to the LVOT may occur above the valve, we call supravalvular stenosis, or below the valve, we call subvalvular stenosis. So the acquired aortic stenosis, the most common cause of aortic stenosis is degenerative calcification of aortic valve, although previously considered to be the result of years of mechanical stress on an otherwise normal valve. The involving concept is that the degenerative process lead to proliferative and inflammatory changes with lipid accumulation and upregulation of angiotensin converting enzymes activity and infiltration of the macrophages and T lymphocytes, ultimately leading to calcification of the aortic valve. A progressive calcification initially allowing the flexion lines at their basis leads to embolization of the cusp. The characteristic pathologic binding are discrete focal lesion on the aortic side of the leaflets that can extend deep into the aortic annulus. The risk factor for the development of calcific aortic stenosis are similar to those of the atherosclerosis and including elevated serum levels of low-density lipoprotein, cholesterol, lipoprotein A, diabetes, smoking, and hypertension. Age-related aortic valve sclerosis is associated with an increased risk of cardiovascular death and myocardial infarction. The growing evidence from retrospective studies demonstrate that therapy with statin is a potential approach to the treatment of the aortic valve disease. Up to 50% of annual reduction in measurable disease progression, whether quantified by Doppler, echocardiographic, jet velocity, or valve area, or by electron beam tomographic valve calcium score, was noted in patients treated with statins. Congenital bicuspid valve with superimposed calcification, calcified bicuspid aortic valve, present the most common form of congenital AS. Bicuspid aortic valve are present in approximately 2% of the general population. A gradual calcification of the bicuspid aortic valve results in significant stenosis, most often in the 5th or 6th decade of the life. Earlier is unicommissural than in bicuspid valve, and earlier in age-related aortic valve. Growing evidence earlier in men than women. The abnormal architectures of unicommissural or bicuspid aortic valve induces turbulent flow, which injures the leaflets and leads to fibrous and increase rigidity and leaflets calcification and narrowing of the aortic valve orifices. Bicuspid valve often are associated with dilatation of the ascending aorta related to accelerated degeneration of the aortic medium that in some cases may progress to aneurysm formation. Recent work suggests that endothelial nitric oxides synthetase may be implicated in the genetic abnormality that lead to bicuspid aortic valve. Calcific aortic valve disease affecting congenital bicuspid or normal trileaflet valve is the most common cause of aortic stenosis in adults. As we should see, these are the pictures. Here's in this slides, we are saying the normal leaflets, the risk of developing aortic stenosis, genotype, valve morphology, age-related, male sex, dyslipidemia, diabetes, metabolic syndrome, hypertension, smoking, renal insufficiency, increased serum phosphatase that's leading to the disease initiation, shear stress, inflammation, lipid infiltration, and fibroblast differentiation, which is eventually leading to progressive disease and causing aortic stenosis by oxidative stress, increased angiotensin 2, and procalcific stimuli of RBG, and the lipoprotein receptor related protein complex, which is eventually leading to hydroxyapatite nodules and cartilage and bone formation, leading to 100% aortic stenosis. So rheumatic aortic stenosis represents the least common form of AS in the adults population. Rheumatic AS is rarely an isolated disease and usually occurs in conjunction with mitral valve stenosis. Rheumatic AS is characterized by diffuse fibrous leaflets thickening of the tricuspid valve with fusion to a variable extent of 1 or 2 commissure. The early stages of the rheumatic AS is characterized by edema, lymphocyte infiltration, and revascularization of the leaflets, whereas the later stage are characterized by thickening, commissural fusion, and scarred leaflets edges. Overall distribution of causes of AS varies significantly among different age groups. Among patients younger than 70 years of age, congenital calcific bicuspid valve were responsible for half of surgical cases. In contrast, in patients over 70 years of old age, degenerative calcific stenosis is by far the most prevalent cause of stenosis, accounting for 48% of all surgical cases. It can be regurgitant aortic stenosis as well as stenotic and rheumatic aortic disease. As we see here, the procedure when there's aortic stenosis, that's leading to the LVO outlet obstruction, which is eventually leading to increased systolic pressure and increased left ventricular ejection time, and increased left ventricular diastolic pressure, and decreased aortic pressure. When we're increasing when the left ventricular systolic pressure increase, this is leading to left ventricular hypertrophied, which is eventually leading to left ventricular leading to increase the myocardial consumption and myocardial demands, which eventually leading to myocardial ischemia, and when it leads to the myocardial ischemia, eventually end with left ventricular dysfunction. When the left ventricular ejection time increase, there will be decrease in the systolic time and increase in the myocardial demand and consumption, which is eventually leading to myocardial ischemia. When there's increase in the left ventricular diastolic pressure and decrease in the aortic pressure, leading to decreased myocardial supply, eventually leading to myocardial ischemia, and when the myocardial ischemia occurs, leading to left ventricular dysfunction and eventually end with left ventricular failure. So the pathophysiology, no appreciable gradient exists across the normal aortic valve during systole, and aortic stenosis, gradual obstruction of the left ventricular outflow tract lead to an increased left ventricular afterload and left ventricular wall stress, elevated left ventricular systolic and diastolic pressure, decreases aortic pressure, and prolonged left ventricular ejection time. Over time, this results in compensatory concepts, left ventricular hypertrophy to maintain ejection fraction. In patients with chronic severe AS, this compensatory mechanism may become insufficient, leading to gradual dilation and thinning of the left ventricle and result in a decreased ejection fraction and in congestive heart failure. Myocardial oxygen supply and demand also is altered in aortic stenosis. The myocardial oxygen demand is increased and the supply is decreased. The left ventricular hypertrophy increased systolic pressure and prolonged ejection time result in increased myocardial oxygen demand. Increased systolic pressure and prolonged systolic ejection time results in decreased systolic and myocardial perfusion time and hence myocardial oxygen supply. The alteration in myocardial oxygen supply and demand is the underlying mechanism behind myocardial ischemia in patients with AS, even in the absence of coronary artery disease. Symptoms, the classical symptoms of AS are angina, exertional syncope, and symptoms of congestive heart failure, such as shortness of breath. Angina, frequent symptoms of a patient with severe aortic stenosis due to decrease the myocardial supply. Syncope reduced due to reduce the stroke volume, which is eventually leading to reduce the cerebral perfusion and GI bleeding. So physical examination, palpation of cardiac upstroke, slow rising, late peaking, low amplitude, evaluation of systolic murmur, assessment of a splitting of second heart sound, signs of heart failures, and crescendo, decrescendo, systolic ejection murmurs, heard best at the second right intercostal space, which is may variable radiate to the carotid arteries. A palpable thrill may be present in severe cases of aortic stenosis. Palpation of the arterial pulse may reveal a weak and delayed pulse known as pulsus parvus et tardus. Okay. Diagnosis and grading, two-dimensional transthoracic cardiography is the most common modality for diagnosis and grading of aortic stenosis. As you see here, we can grade the aortic stenosis according to aortic valve areas. Mild, it's 1.6 to 2.5 square centimeters is considered mild, and the moderate is from 1.1 to 1.5, less than 1, it's considered severe. The mean pressure gradients, if it's less than 20, it's considered mild. If it's more at between 20 to 39, it's considered moderate. And if it's more than or equal 40, it's considered severe. Aortic jet velocity, if it's between 2 to 2.9, it's considered mild, and if it's 3 to 3.9, it's considered moderate, and if it's more than 4, it's considered to be severe. The investigation, we did ECG. We might find left ventricular hypertrophy and left bundle branch block according to the stage of the disease, and chest X-ray may be normal or maybe enlarged left ventricle, dilated ascending aorta, in posterior anterior view. Calcified valve on lateral view can be seen. Echo calcified valve with restricted opening and hypertrophied left ventricle may be seen. Doppler measurement of the severity of stenosis and detection of associated aortic regurgitation. Cardiac catheterization to identify co-assistant coronary artery disease may be used to measure gradient between the LV, the left ventricle, and the aorta. Natural history without intervention, multiple studies consistently reported survival of 3 years for aging and for angina and syncope, 1.5 to 2 years for dyspnea and heart failure. These findings have driven recommendation for early surgical intervention in patients with symptomatic AS. 1/3 of symptomatic patients of severe AS will become symptomatic in 2 years with an estimated cardiac death of less than 1% each year to 5% each year. Patients with higher grades of AS severe seem to progress at a faster rate than lower graded of AS. After aortic stenosis become moderate, aortic valve area by 0.1 square centimeter per year. The pressure gradient aortic across the valve rises on the average by 7 millimeters mercury per year, and the jet velocity increases by 0.3 meter per second per year. So the management in asymptomatic aortic stenosis kept under review. Aortic stenosis, the development of angina, syncope, symptoms of flow cardiac outputs, or heart failure has a poor prognosis and an indication for promote surgery. Moderate or severe stenosis evaluated every 1 to 2 years without Doppler echocardiography to detect progression in severity. In symptomatic severe aortic stenosis, valve replacement is recommended. Congenital aortic stenosis, aortic balloon valvoplasty is the best choice, and atrial, if there is atrial, patient develop atrial fibrillation or post-valve replacement with a mechanical prosthesis, he needs to be anticoagulated by warfarin or any other anticoagulant. Aortic regurgitation, as aortic regurgitation is the systolic reflux of the blood from the aorta into the left ventricle, owing to failure of coaptation of the valve leaflets during the assault. The presentation varies depending on the acuity of onset, severity of regurgitation, compliance of ventricles and aorta. Hemodynamic conditions prevalent at the time, whereas the chronic AR is well tolerated for years. Acute AR can be debilitating and life-threatening if not treated emergently. In general, the causes can be divided into affect valve cusp or affecting aortic root. Affect valve cusp degeneration, congenitally bicuspid valve, infective endocarditis, rheumatic disease, myxomatous degeneration, and the level of aortic roots, aortic dissection, aortitis of various etiologies such as syphilis, connective tissues disorders such as Marfan syndromes. As we say, primary valve disease could be congenital, rheumatic heart disease, infective endocarditis, collagen vascular disease, degenerative aortic valve, myxomatous prolapse, traumatic. A primary root uncontrolled hypertension, Marfan syndrome, idiopathic aortic dilatation, and dilatation, aortic dissections, Marfan syndromes, septic aortitis, giant cell arthritis, Takayasu arthritis, and ankylosing spondylitis, Weber disease. Acute aortic regurgitation, by the definition, acute AR is hemodynamically significant aortic incompetence of sudden onset across a previously competent aortic valve into a left ventricular not previously subjected to volume overload. The inability to adapt is worse for concentrically thickened hypertrophic myocardium, typically seen in those with chronic hypertension. Disease states that typically present in this acute fashion, including endocarditis, trauma, or aortic dissection. Chronic aortic regurgitation has numerous causes, which can be grouped according to the structural component of the valve affected. The valve leaflets may be disorders, thereby preventing a proper valve coaptation, calcific aortic disease, idiopathic degenerative disease, active or chronic aortic valve endocarditis, rheumatic disease, and bypass aortic valve, and myxomatous proliferation of aortic valve tissues all prevent the valve cusp from closure properly. More recently, anaerobic medications such as fenfluramine and phentamine have been found to cause aortic valve distortion from generated leaflets, leading to regurgitation similar to that seen in carcinoid syndrome. Aortic annular dilatation will prevent the aortic cusp from closure properly, aortic stenosis as well as leading to valve insufficiency. Aortic dissection, trauma, chronic systemic hypertension, aortitis from syphilis, varial syndromes, or other systemic arthritis, giant cell and Takayasu, and connective tissues disorders such as Marfan's syndrome or Ritter disease or Ehlers-Danlos syndromes or osteogenesis imperfecta or rheumatoid arthritis all lead to annular dilatation and valvular insufficiency. Pure aortic regurgitation is rare and is seen commonly only in aortic dissection or in pathophysiological process causing annular dilatation. Chronic aortic regurgitation we can hear early diastolic murmur, high pitch blowing, decrescendo, best heard in third left intercostal space with the patient sitting up expiration. Aortic root disorders, murmur is best heard along the right sternal border, mosaical murmurs, longer the duration of the murmur, more severe, or the aortic regurgitation becomes short, indicating cardiac failure. Austin Flint murmur is soft, low pitched rumbling, mid-diastolic murmur, diastolic displacement of the anterior leaflets of the mitral valve by aortic regurgitation steam. The pathophysiology of the AR dependent on the acuity of the onset and duration of the disease process. Acute AR typically caused by aortic dissection, effective endocarditis, trauma, or valve prosthesis failure. This is a sudden increase in left ventricular end-diastolic volume because of regurgitation, since the left ventricle has limited compliance and does not have time to adapt. The left ventricular end-diastolic pressure rises rapidly. Acute AR results in a dramatic increase in left ventricular end-diastolic pressure, and the mitral valve may close earlier in the late diastolic to reduce the amount of the left atrial blood entering the ventricles, thereby preventing the backflow into the left endoatrium and pulmonary veins, and pulmonary which pressure increases with the resulting pulmonary edema and the normally widened pulse pressure of chronic aortic regurgitation is attenuated or non-existent in the acute AR, owing to the rapid rise in diastolic pressures. Effective cardiac output is less than that of the chronic state because compensatory dilatation has not occurred, and hence left ventricular end-diastolic volume remains larger than normal, but small conversion with effective stroke volume. Compensatory changes in heart rate occurs higher than those of a chronic aortic regurgitation to augment cardiac output. Overall, the hemodynamic effect of acute aortic insufficiency produce a low effective cardiac output with an elevated left ventricular diastolic pressures and heart rate, which is are maintained in previous balance and leading to those onset of early congestive heart failure with any perturbation in the diastolic filling of the heart rate. As you see here is the aortic regurgitations. There is the diastolic regurgitation increasing in the left ventricular volume, increases systolic volume, and decrease in aortic diastolic pressure and decrease effective stroke volume leading to fatigue. When the left ventricular volume increase, leading to the left ventricle to be hypertrophied and increase myocardial consumption, and when increase the myocardial consumption, this is leading to MI due to decrease the myocardial supply. Increase the stroke volume, leading to increase the systolic pressure. When increase the systolic pressure, leading to left ventricular hypertrophy and increase the myocardial demand and left ventricular dysfunction. When increase the left stroke volume, leading to increase the left ventricular ejection time, which is leading to decrease the diastolic time and decreasing the myocardial supply to the myocardial tissue, leading to myocardial ischemia. And when the effective stroke volume decrease, leading to decrease in myocardial supply and the myocardial ischemia, which is eventually leading to increase left ventricular and diastolic pressure and dyspnea, and eventually leading to left ventricular dysfunction and eventually leading to left heart failure. The pathophysiology of chronic AR. Chronic AR, there is a slow and insidious progression of left ventricular dilatation and eccentric hypertrophy because of an increase in left ventricular and diastolic volume, left ventricular and diastolic pressure, and wall stress. Dilatation of the left ventricle while maintaining normal systolic function increases total stroke volume and maintains forwards flow. This increase in stroke volume coupled with an increase in left and systolic pressure is associated with the wide pulse pressure, typically of a chronic aortic regurgitation. Eventually, the hypertrophic response is exhausted and left ventricular ejection fraction drops and as afterload increases, leading to heart failure and its associated with clinical presentation. The clinical features in acute AR usually exhibit sudden or rapidly progressive cardiovascular collapse, which can be life-threatening if not addressed remotely. They often exhibit ischemic symptoms because of decrease in coronary blood flow and increased myocardial oxygen demand. The chronic AR asymptomatic for long period of times because of the compensatory left ventricular changes. Once the compensatory response is exhausted, the patient is starting to having heart failure symptoms like palpitation, early symptoms, head bowing on exertion, and exertional dyspnea, orthopnea, paroxysmal nocturnal dyspnea, excessive orthopnea, diaphoresis, angina on exertion or at rest nocturnal, and chronic congestive cardiac failure later on. So chronic aortic regurgitation, early this we can hear early diastolic murmur, high pitched flowing, decrescendo, best heard in the third left intercostal space with the patient sitting up and leading forward, breath held in forced expiration, aortic root disorders. Murmur is best heard along the right sternal border mosaical murmurs, long the duration of murmurs, more severe of the aortic regurgitation becomes short if there is cardiac failure. Austin left Flint murmur, soft, low-pitched rumbling mid-diastolic murmurs. Pulse in aortic regurgitation, classical signs of widened pulse pressure may also be found, including Corrigan or water hammer pulse, Demoiselle signs, popping of the head with heartbeats, or Quincke pulse, pulsation of the lips and fingers, or tropy pulse, postal, short sound over the femoral artery, Miller signs, pulsation of the uvula, Baker signs, visible systolic pulsation of the retinal arterioles, and lighthouse signs, alternate flushing and blanching of the forehead, Landlof's signs, the change in the pupil size with each systole, and Gerhardt's signs, visible systolic pulsation of spleen, Risenbach signs, visible systolic pulsation of liver, and Corrigan signs, dancing carotid in neck, a Hill sign, popliteal cuff systolic pressure exceeding brachial cuff systolic pressure by more than 20 millimeter mercury. Diagnostic criteria, we did ECG, we might find left ventricular hypertrophy, left axis deviation, left atrial enlargement, left ventricular volume overload pattern, prominent Q waves, leads 1, AVL, and V3 to V6, and relatively smaller R waves in V1. Chest X-ray, we might in acute AR, there may be minimal cardiac enlargement, but marked enlargement is a common finding in chronic AR. Transthoracic echocardiography with Doppler color flow is the most useful tool for the diagnosis of aortic regurgitation. The jet width and the vena contracta width on Doppler color flow are used to quantitatively assess the severity of AR, whereas the regurgitation volume, regurgitant fraction, and regurgitant orifices areas are used for the quantitative assessment. As we see here, we're calculating the LVOT with jet velocity. If it's trace, it will be less than 10%, mild 10 to 24%, moderate 25 to 65, and severe more than 65%. And vena contracta width, if it's less than 3 millimeter, consider mild, 3 to 6 millimeter moderate, and if it's more than 6 millimeter, it's considered to be severe. This is echocardiographic stages of chronic aortic regurgitation. As you see, dimension and diastolic dimension. Less than 60 compensated, transitional 60 to 70, and if it's more than 75, it's decompensated. And the diastolic dimension in millimeters, if it's less than 45, it's compensated. If it's between 45 to 50, it's transitional. If it's more than 55, it's decompensated. According to the volume and the diastolic volumes, if it's less than 120, it's compensated. Between 130 to 160, it's transitional. If it's more than 170 milliliter per square meters, is decompensated. Left ventricular function, if ejection fraction is more than 55, it's compensated. Transition, if it's between 51 to 55, if it's less than 50, it's decompensated. Cardiac catheterization, classic class 1 indication for cardiac catheterization under current ACC or AHA guidelines. Assessment of coronary anatomy prior to aortic valve surgery in patients with risk factors for coronary artery disease. Assessment of severity of AR, left function, or aortic root size with non-invasive are inconclusive or are discordant discoordinate with the clinical finding. Aortic angiography, mild +1, a small amount of contrast enter the left ventricle during the systolic and clears with each systole. Moderate AR +2 contrast enter the left ventricle with each diastole, but the left ventricular chamber is less dense than the aorta. Moderate severe AR +3, the left ventricular chambers is equal in density to the ascending aorta. Severe AR +4, complete dense ossification of the left ventricular chambers occur of the first beat, and the left ventricle is more densely ossified than the ascending aorta. Cardiac MRI provide accurate measurements of regurgitation volume and the regurgitant orifices in AR. It is the most accurate non-invasive technique for assessing left ventricular and diastolic volume, the diastolic volume, and the mass of the myocardium. Management in chronic regurgitation, compensated chronic AR is well tolerated by most patients. Aortic valve replacement is currently not recommended for patients who are asymptomatic, even with severe chronic AR. These patients, however, must have normal ventricular function and good exercise tolerance. In asymptomatic patient, AVR is indicated for deteriorating ventricular function. Aortic valve replacement is indicated in patients develop symptoms of congestive heart failure or decreased exercise tolerance or decreased exercise tolerance. However, decreased ejection fraction during exercise is not a good measure to indicate the need for the valve replacement in symptomatic patient with normal systolic function at rest. The lack of correlation between the exercise ejection fraction and the need for the operation lies in that exercise ejection fraction depends on the multiple factors, and no study have shown conclusive proof linking exercise ejection fraction with mortality both preoperatively or to be of prognostic valve post-operatively. This is our reference. Thank you for listening. That's the end of my presentation. Any question?
So any question or comment for Dr. Isa? So we'll have a 10-minute break. Then we'll start 2:30 inshallah with Dr. Khalid inshallah. So Khalid, if you are ready, you can start.
Okay, Assalamu alaikum. Good afternoon, everyone. My name is Khalid Al-Girni. I'm a cardiac surgery resident at King Fahd. My talk, inshallah, will be on AVR with mechanical prosthesis and latest guidelines. My outlines for my presentation today will start with the latest American Heart Association and American College of Cardiology 2020 guidelines, mainly speaking on indications for AVR and valve selection and anticoagulation for aortic valve replacement. Then we'll talk little on history of mechanical prosthesis, and we'll move then to the approach and surgical techniques for mechanical AVR. And lastly, we'll speak about patient prosthesis mismatch. So starting with the guidelines, first of all, stages for valvular heart disease, generally speaking, is subclassified into 4 main stages. From stage A, for patient being at risk for development of valvular heart disease or aortic stenosis in this case, like having some from valve anatomy feature like a bicuspid aortic valve or congenital valve anomaly or aortic valve sclerosis. In terms of valve hemodynamics, usually for aortic stenosis, the aortic velocity is less than 2 meters per second with normal leaflet motion and with no hemodynamic consequences and no symptoms. For stage B, for patient with a progressive aortic stenosis, mainly mild to moderate severity and asymptomatic. And they might have some valve anatomy feature like mild to moderate leaflet calcification or fibrosis, or some rheumatic valve changes like commissural fusion. And in terms of valve hemodynamics, they tend to have mild to moderate severity. For grading aortic stenosis, usually they have velocity between 2 to 2.9 meters per second, or mean pressure gradient of less than 20 in terms of mild aortic stenosis. And for moderate aortic stenosis, the aortic peak velocity ranges between 3 to 3.9, and for mean peak pressure gradient is from 20 to 39 meter mercury. And in terms of hemodynamic consequences, they tend to have early LV diastolic dysfunction and normal ejection fraction and no symptoms. Moving to stage C, which is usually asymptomatic patients subgroup, but with severe aortic stenosis, and it's subclassified into C1 and C2. C1 if the patient had normal function, and C2 with reduced function. So for stage C1, asymptomatic severe aortic stenosis, the valve anatomy might be with severe leaflet calcification or fibrosis or congenital stenosis with severely reduced leaflet opening. And in terms of hemodynamic, they tend to have severe grade 4 aortic stenosis with maximum velocity equals or more than 4 meters per second, or mean pressure gradient, mean peak pressure gradient of 40 millimeter mercury or above, and aortic valve area typically is equal or less than 1 centimeter square, or the index area is 0.6 centimeter square per meter square, but not required. to define the severity of aortic stenosis. And for the very severe aortic stenosis subcategory, they tend to have aortic high velocity of equal or more than 5 meters per second, or the mean pressure gradient of 60 millimeter mercury or above. And in terms of hemodynamic consequences, the LV diastolic function might be present or with mild LV hypertrophy, but still with normal left ventricular ejection fraction, and they tend to have no symptoms. For stage C2, for asymptomatic patient with severe aortic stenosis and LV systolic dysfunction, and they tend to have similar valve anatomy features and similar valve hemodynamics, but with reduced left ventricular ejection fraction and still no symptoms. Moving to stage D for symptomatic patient with severe aortic stenosis, it's also in this case subclassified into 3 stages for aortic stenosis. Stage D1, when we have a patient with symptomatic severe high gradient aortic stenosis with same valve anatomy features as the previous class, and with severe valve hemodynamics grading for aortic maximum velocity of 4 or more meter per second, or mean pressure gradient of 40 millimeter mercury or above, and the aortic valve area also will be equal or less than 1 centimeter square. For hemodynamic consequences, patients might have LV diastolic dysfunction or LV hypertrophy, pulmonary hypertension, all may be present, and the symptoms usually exertional dyspnea, decreased exercise tolerance, heart failure, or exertional angina, or exertional syncope or presyncope. For stage D2, when we have a symptomatic patient with severe but low flow, low gradient aortic stenosis and reduced LV ejection fraction. In terms of valve hemodynamic, usually the aortic valve area is equal or less than 1 centimeter square, with resting aortic valve peak velocity of less than 4 meters per second, or mean pressure gradient of less than 40 millimeter mercury. So it's a low flow, low gradient, basically. And upon using the vitamin stress echo, it shows relatively same aortic valve area, but the peak velocity will be equal or more than 4 meters per second at any flow rate. And they tend to have LV diastolic dysfunction, hypertrophy, and reduced ejection fraction, and same symptoms as the previous group. For stage D3, when we have symptomatic patient with severe low gradient aortic stenosis with normal left ventricular ejection fraction, or what we call it a paradoxical low flow severe aortic stenosis. In this subclassification, usually the aortic valve area is equal or more less than 1 centimeter square, or the index area of equal or less than 0.6 centimeter square per meter square, with an aortic peak velocity of less than 4 meters per second, or mean pressure gradient of less than 40 millimeter mercury, and the stroke volume index is less than 30 ml per meter square. And it's usually measured when patient is normotensive, with systolic blood pressure is less than 140 millimeter mercury. In terms of hemodynamic consequences, they tend to have increased LV relative wall thickness. That's why the ventricle is unable to accommodate a large stroke volume. And with this small LV chamber, they tend to have low stroke volume and restrictive diastolic filling. That's why they have a low flow state and low gradient. So moving for the guidelines in terms of indication for aortic valve replacement for symptomatic severe high gradient aortic stenosis, the stage D1 and symptoms of exertional dyspnea, heart failure, or angina, or syncope, or previous syncope by history or in exercise testing, AVR is indicated as a class 1. And for asymptomatic patient with severe aortic stenosis and reduced ejection fraction, stage C2, AVR is indicated as well as a class 1. And for asymptomatic patient with the stage C1, severe aortic stenosis, who are undergoing cardiac surgery for other indications, AVR is indicated as a class 1 as well. For symptomatic patients with low flow, low gradient, severe aortic stenosis and reduced LV ejection fraction, stage D2, AVR is recommended as a class 1 as well. And for symptomatic patient with low flow, low gradient, severe aortic stenosis, but normal LV ejection fraction, stage D3, AVR is recommended if the aortic stenosis is the most likely cause of symptoms as a class 1. For asymptomatic patient with severe aortic stenosis, stage C1 and low surgical risk, AVR is reasonable when an exercise test demonstrates decreased exercise tolerance or fall in systolic blood pressure of more than 10 millimeter mercury from the baseline to peak exercise as a stage 2A. For asymptomatic patient with very severe aortic stenosis, defined as we said, if the aortic peak velocity of equal or more than 5 meters per second and low surgical risk, then AVR is reasonable as a class 2A. For asymptomatic patients with severe aortic stenosis, stage C1 and low surgical risk, then AVR is reasonable when the serum BNP level is 3 times higher than the normal range as a stage 2A. And for asymptomatic patients with high gradient severe aortic stenosis, stage C1 and low surgical risk, then AVR is reasonable when serial testing show an increased aortic velocity of equals or more than 0.3 meter per second per year as a stage 2A. And for asymptomatic patient with severe high gradient aortic stenosis, stage C1, with progressive decrease in left ventricular ejection fraction on at least 3 serial imaging studies to less than 60%, then AVR may be considered as a class 2B. For patients with moderate aortic stenosis who are undergoing cardiac surgery or other indication, AVR may be considered as a class 2B. And this diagram summarizes the timing for intervention of aortic stenosis as we discussed. Moving to aortic regurg, also we have, as we said, 4 stages for classifying valvular heart disease severity. Stage A, when we have a patient with risk factor for development of aortic regurg, like in terms of valve anatomy, having a bicuspid aortic valve or aortic valve sclerosis or diseases of the aortic sinuses or ascending aorta, having history of rheumatic fever or non-rheumatic heart disease, and infective endocarditis. And the stage A, they tend to have no or usually trace AI with no hemodynamic consequences and no symptoms. For stage B, with progressive aortic regurg, having mild to moderate severity. For mild AI, usually with jet width of less than 25% of the LVOT and vena contracta of less than 0.3 centimeter and regurgitant a volume of less than 30 ml per beat, and the regurgitant fraction of less than 30% and effective regurgitant orifice of less than 0.10 centimeter square, and angiographically a grade 1 aortic regurg. For moderate aortic regurg, the jet width between 25 to 64% of the LVOT, and the vena contracta of 0.3 to 0.6 centimeter, and the regurgitant volume between 30 to 59 ml per beat, and the regurgitant fraction of 30 to 49%, and the effective orifice area of 0.10 to 0.29 centimeter square, and angiographic grade 2. And they tend to have normal LV systolic function and normal LV volume or mild LV dilatation, and still with no symptoms. For stage C, having a patient with asymptomatic but severe aortic regurg, the jet width will be more than or equal to 65% of the LVOT, and the vena contracta of more than 0.6 centimeter, and having a hollow diastolic flow reversal in the proximal abdominal aorta or the descending thoracic aorta, regurgitant volume of 60 ml or more than per beat, and the regurgitant fraction of equal or more than 50%, and the orifice area, orifice effective regurgitant orifice of equal or more than 0.3 centimeter square, and then geographic grade 3 to 4. In addition, diagnosis of chronic severe AI requires evidence of LV dilatation. Also for stage C, aortic regurg, it's subclassified to C1 when we have normal ejection fraction, but with mild to moderate LV dilatation. The left ventricular end systolic dimension less than 50 millimeter. And for stage 2, when we have C2, when we have abnormal LV systolic function with the depressed ejection fraction less than or equal to 55%, or severe LV dilatation when we have the left ventricular end systolic dimension of more than 50 millimeter, or the index dimension of more than 25 millimeter per meter square. And they tend to have no symptoms. For stage D, having a patient with symptomatic severe aortic regurg, usually the valve hemodynamic as in the previous subgroup. And in terms of hemodynamic consequences, patient with symptomatic severe aortic regurg, it may occur with normal left ventricular ejection fraction, with mild to moderate LV dysfunction as well, or severe LV dysfunction with moderate to severe LV dilatation is present. And they tend to have exertional dyspnea or angina or more severe heart failure symptoms. So moving for the indication of AVR for patients with aortic regurg. So for symptomatic patient with severe aortic regurg, stage D, aortic valve surgery is indicated regardless of the LV systolic function as a stage, as a class 1 recommendation. In asymptomatic patient with chronic severe AI and LV systolic dysfunction of defined as left ventricular ejection fraction of less than or equal to 55%, stage C2, then aortic valve surgery is indicated if no other cause for systolic dysfunction is identified as a class 1. For patients with severe AI, stage C or D, who are undergoing cardiac surgery for other indication, then aortic valve surgery is indicated as a class 1. For asymptomatic patients with severe AI and normal LV systolic function, defined as left ventricular ejection fraction of more than 55%, then aortic valve surgery is reasonable when the LV is severely enlarged, having a left ventricular end systolic dimension of more than 50 millimeter, or the index dimension of more than 25 millimeter per meter square, is indicated as a class 2A. For patients with moderate AI, stage B, who are undergoing cardiac or aortic surgery for other indication, then aortic valve surgery is reasonable as a class 2A. Unlike having a patient with moderate aortic stenosis undergoing other cardiac surgery, it's a class 2B to intervene. For asymptomatic patient with severe AI and normal LV systolic function at rest, stage C1 with low surgical risk, then aortic valve surgery may be considered when there is a progressive decline in the LV ejection fraction and at least 3 severe studies to low or low normal range, AF between 55 to 60%, or progressive increase in LV dilatation into the severe range when we have the end diastolic dimension of more than 65 millimeter. For patients with isolated severe AI who have indication for surgical AVR and are candidate for surgery, then TAVI should not be performed. It's a class 3 harmful. And this diagram summarizes the indication for surgery in case of aortic regurg as we discussed before. Moving to another section, which is the choice of prosthesis, mechanical versus prosthetic, bioprosthetic valves for aortic valve replacement. In patient with an indication for AVR, the choice of prosthetic valve should be based on a shared decision-making process that accounts for the patient's value and preference and includes discussion of the indications for risk of anticoagulation therapy and the potential need and risks associated with the re-intervention. For patients of any age requiring AVR, for whom vitamin K antagonist anticoagulant therapy is contraindicated or cannot be managed appropriately or is not desired, then a bioprosthetic AVR is recommended as a class 1. For patients less than 50 years of age who don't have a contraindication to anticoagulation and require AVR, then it's reasonable to choose a mechanical aortic prosthesis over a bioprosthetic valve as a class 2A. And for patients 50 to 65 years of age who require AVR and who don't have a contraindication to anticoagulation, then it's reasonable to individualize the choice of either a mechanical or bioprosthetic AVR with consideration of individual patient factors and after informed shared decision-making process as a class 2A. And for patients elder than 65 years of age who require AVR, then it's reasonable to choose bioprosthesis over a mechanical valve as a class 2A. And for patients less than 50 years of age who prefer a bioprosthetic AVR and have appropriate anatomy, then replacement of the aortic valve by a pulmonic autograft, which is the Ross procedure, may be considered at a comprehensive valve center as a class 2B. So if the for shared decision-making for prosthetic valve choice, if the patient having a vitamin K antagonist anticoagulation either contraindication or cannot be managed or not desired, then go for bioprosthetic valve as a class 1. If vitamin K antagonist is okay, then we'll subclassify patient by age group, and of course will account for other variable. If the age is less than 50 years, then mechanical AVR is a class 2A. Between 50 to 65, mechanical or bioprosthesis, both are class 2A. More than 65 years of age, then bioprosthesis is a class 2A. So for the factor that usually favor mechanical prosthesis having an age less than 50 years or with increased incidence of structural deterioration with bioprosthesis, for example, the 15-year risk is 30% for a patient who age 40 years, while it's 50% risk for deterioration for a patient who had a bioprosthesis at the age of 20 years. And the lower risk of anticoagulation complication. These factors favor mechanical prosthesis. Also patient preference or low risk of long-term anticoagulation, having a patient who's compliant with either home monitoring or close access to INR monitoring, or having another indication for long-term anticoagulation like atrial fibrillation, or having a high-risk re-intervention like porcelain aorta prior radiation therapy, or patient with small aortic root size for AVR, which may preclude valve procedure in the future. All these factors favor mechanical prosthesis. On the other hand, having a patient who is elder than 65 years of age or with low incidence of structural deterioration, like having a bioprosthesis for patient who is elder than 70 years of age, the 15-year risk of structural deterioration is less than 10%, and higher risk of anticoagulation complications, patient preference, and high risk of long-term anticoagulation, or patient with limited access to medical care. or he's unable to regulate the INR and adjustment of warfarin therapy, or if there is access to surgical centers with low reoperation mortality rate, or access to a transcatheter valve replacement center, or where TAVI valves have a larger effective orifice area or smaller valve size to avoid patient prosthesis mismatch. All these factors favor bioprosthesis. Moving to anticoagulation section for prosthetic valve. For patient with a mechanical prosthetic valve, then anticoagulation with a vitamin K antagonist is recommended as a class 1. And for patients with mechanical Bielefeldt or the current generation single tilting disc, AVR, and no risk factors for thromboembolism, then anticoagulation with a vitamin K antagonist to achieve an INR of 2.5 is recommended as a class 1. And for patients with a mechanical AVR and additional risk factor for thromboembolism, like having atrial fibrillation or history of previous thromboembolism or LV dysfunction or hypercoagulable state, all these are risk factors for thromboembolism, or having an older generation prosthesis like ball and cage, which we will discuss in the next slide. Then anticoagulation with a vitamin K antagonist is indicated to achieve an INR of 3 as a class 1. For patient with the bioprosthetic surgical AVR or mitral valve replacement who are at low risk of bleeding, then anticoagulation with a vitamin K antagonist to achieve an INR of 2.5 is reasonable, at least 3 months, or as long as 6 months after surgical replacement as a class 2A. And for all patients with a bioprosthetic surgical AVR or mitral valve replacement, addition of aspirin 75 to 100 milligram daily is reasonable in the absence of other indication for oral anticoagulant as a class 2A. And for patients with a mechanical surgical AVR or mitral valve replacement who are managed with a vitamin K antagonist and have indication for antiplatelet therapy, then addition of aspirin at low dose may be considered when the risk of bleeding is low as a class 2B. And for patients with the mechanical Onyx AVR with no thromboembolic risk factors, the use of vitamin K antagonists targeting a lower INR of 1.5 to 2 may be reasonable starting at 3 or more months after surgery with continuation of aspirin daily, low dose aspirin daily. It's a class 2B. And for patients with bioprosthetic TAVI who are at low risk for bleeding, then dual antiplatelet may be reasonable for 3 to 6 months after valve implantation. For patients with a mechanical valve prosthesis, anticoagulation with a direct thrombin inhibitor like dabigatran is contraindicated. It's a class 3 harmful. And for patients with a mechanical valve prosthesis, then the use of anti-factor 10A direct oral anticoagulant has not been assessed and is not recommended, as still class 3 harmful. So this diagram summarizes what we discussed before. For a mechanical valve prosthesis, the target INR is for mechanical aortic valve replacement is 2.5, and it's with the new generation aortic valve like Onyx and no thromboembolism risk factors, then targeting a lower INR of 1.5 to 2.5 is a class 2B. And for mechanical AVR with other risk factor for thromboembolism, then we'll target a higher INR, or when you have a patient with all generation prosthesis. And addition of low dose aspirin for with vitamin K antagonist is may be considered as a class 2B. So before we move to the surgical techniques of aortic valve replacement with mechanical prosthesis, it's worth mentioning some facts on the history of aortic valve mechanical prosthesis. So as you can see here, this is the first aortic valve. It's called a ball and cage generation, which was used initially in the descending aorta. It's not in the it's called the heterotypical position, not in the orthotypic position, not in the supracoronary position. And after the invention, till after the invention of the cardiopulmonary bypass, then the first successful AVR was done with this model in the supracoronary position, and it remained as standard of care for almost a decade. But with the multiple modification has been done to overcome the problem of this degeneration, include intense anticoagulation need with hemodynamic compromise and having an abnormal flow pattern with the high distance between the cage and the aortic wall, plus the distance of the disturbance of the flow by the ball itself. Then the second generation of aortic valve prosthesis, we can see it here in the middle of the screen, which is the tilting disc prosthesis with the different models came and implanted in the late 1960s to 1980. And it has a low profile configuration which simplified its implantation. But also it has some disadvantages in terms of stasis and sticking or embolization of the leaflet and eddy current formation at the minor flow orifice. And next we have the third generation, or what we call it as a bileaflet aortic valve prosthesis. With this model by Kalki and Lilhi. It was first implanted, and then St. Jude Medical introduced in the late 1977, and different models were introduced to the market, like Carbomedics by Sulzer and ATS Medical and Onyx Valve. And these valve having a low, it demonstrated usually a low gradient and with minimal aortic regurg residual and low thromboembolism risk and low profile design and having lesser extent for need of anticoagulation, which is the standard of care nowadays. So moving to the surgical techniques and approach to aortic valve replacement, starting with the incision. Usually it's a median stenotomy, either full or limited skin incision, or what we call it in minimal invasive AVR as upper main stenotomy, or the J incision, or right anterior thoracotomy is also an other alternative for minimal invasive AVR, which will be discussed in another session. So after ascending aorta has been cannulated in the usual fashion, with cannulation and snaring of the arterial cannula, and here we can see dual stage venous cannula in the right atrium. And in case of combined procedure like mitral or tricuspid valve, then a bicaval cannulation is needed, of course. We have different myocardial preservation techniques, depends on the surgeon and his preference and practice. Here, the retrograde aplysia placed on the coronary sinus and antegrade on the aortic root as shown. Then the cardiopulmonary bypass is initiated, and cooling down for moderate hypothermia, for applying cross-clamp in a cold blood cardioplegia into the aortic root till myocardial activity stops and the ECG monitor reveals a flat line. Few points here worth mentioning while administering Plegia. One of these issue is LV distension, which we need to avoid, and to have a successful arrest with antegrade administration of cardioplegia into the aortic root, we have to have a competent aortic valve. In case of incompetent aortic valve, then a significant AI resulting backflow of cardioplegia solution into the non-contracting LV cavity, resulting in LV distension at myocardial injury. And therefore, to avoid this problem when aortic valve is incompetent, we use retrograde cardioplegia technique, and we tend to place an LV vent in the right superior pulmonary vein, and myocardial protection could be augmented by giving cardioplegia directly in the coronary ostia after the aorta is opened, as we see here, either using a protecting tip or the cannula with the balloon itself. If retrograde cannula cannot be introduced, then a bicaval cannulation is an alternative with direct retrograde cannula can be placed in the coronary sinus after opening the right atrium under direct vision. Retrograde cardioplegia, usually it's slow in arresting the heart, especially if we have a patient with enlarged heart. And if this is the case, then a direct cardioplegia after aortotomy can be administered directly in the coronary ostium. RCA, air embolism, can happen during AVR, and to prevent this, usually we tend to give retrograde warm blood infusion as continued after removing cross-clamp to minimize the risk of air bubbles trapped into the aortic root, entering the right coronary artery. Moving to exposure of the aortic valve, we have two main techniques for exposing the aortic valve: transverse aortotomy and oblique aortotomy. Starting with the transverse aortotomy via a low transverse incision, which is the most commonly used at 10 to 15 millimeter from the origin of the RCA. The epicardial fat is retracted at the adventitia around the arteriotian pulmonary artery. We may dissect it and retract it with a few obligated suture to facilitate the exposure, and we can use a fine Prolian stitch on each side of the incision in the adventitia of the aortic wall, at least 10 millimeter above the origin of the RCA. And once the aorta is cross-clamped, the aortic wall is incised between these suture, and the leaflet retractor is then introduced into the lumen for exposure. We need to be careful while introducing it to avoid injury, which can happen if the aortic wall is dilated and thinned out, usually for elderly patient with severe aortic stenosis and post-stenotic dilatation of the aortic root. And aggressive traction may result in a transverse tear of the aortic root wall as well. And to repair this complication, This might necessitate the replacement of the ascending aorta or patch repair of the aortic wall, and then the direct lesion, the opening is extended in both sides, stay approximately 10 millimeter above the aortic commissures, and alternatively the incision is extended oblique, upward or downward, converting it to the oblique incision to provide an optimal exposure. Another problem is having aortotomy too close to the right coronary ostia, and it tends to happen with patient with post-stenotic dilatation in case of aortic stenosis and congenital bicuspid aortic valve, which may distort the aortic root and leads to upward displacement of the right coronary ostia. So the transverse aortotomy may be too low and impinge on the right coronary ostium, so care must be taken to identify the origin of the RCA before opening the aorta, and try to stay at least 10 millimeter to 15 millimeter above the origin of the RCA. Moving to oblique aortotomy, it's other technique for exposure, and this incision is particularly useful in patients with a small aortic root. The oblique or hockey stick incision is started high in the medial aspect of the aorta and is continued diagonally to the non-coronary sinus, stopping 10 millimeter above the annulus. And the aortic wall is then retracted on each side. Here we can see different pathologic morphologies after accessing the aortic valve and examining it. Here we can see the classic degenerative changes with hypocalcification. And here we can see the bicuspid aortic valve. And here we can see some of the rheumatic changes like commissural fusion and thickening. So moving to the steps of aortic valve replacement, starting with the excision of the valve and debriding the valve and sizing the annulus for a proper prosthesis to be implanted. Then suture insertion into the annulus and the sewing ring of the valve, and seating the valve into the annulus, and finally closing the aortotomy incision. So starting with excision of the aortic valve, leaflet excision start using scissors, leaving a 1 to 2 millimeter margin at the annulus, and the calcification crushed by rongeurs and excised. However, excision should be limited and not to get too close to the annulus, which may disrupt the annulus and leave a little tissue to hold the suture. Therefore, a margin of valve leaflet should be left behind and can be trimmed away later. Here, care must be taken not to allow a calcium particle to fall into the LV cavity because they can embolize. So we can use the sucker tip, detach it, and the assistant must use the suction or in this stage to suck all the debris and the leaflets being excised. And another way is to use a folded sponge and place it in the LV after valve excision before removing the calcium from the annulus to guard the LVOT. And the LV cavity is then flushed and irrigated with cold saline solution, and then the sponge is then removed. To protect coronary from calcium particle embolization, we can use a cotton swab or a cardioplegia cannula, and also the tip of the suction head to protect the coronary ostium. And usually the embolization tends to happen in the left coronary ostium more than the right, because the right ostium is more anterior in position and often covered by the retractor used. Another complication to avoid is the anterior mitral valve leaflet detachment from the annulus because of its continuity. So during excision and of the aortic leaflet, calcium removal from the annulus near the left coronary cusp and the non-coronary cusp, the aortic mitral valve leaflet and the continuity might be disrupted here, leading to disruption of the mitral valve. And if this happens, then it has to be reattached to the annulus by interrupted bridgeted suture, incorporating the torn edge of the mitral valve and the annulus. Another complication is annular weakness that can happen with aggressive pulling of the calcium from the annulus, and this might occasionally weaken the area, and it must be recognized and approximated with ablated suture. So it's important, as discussed in the previous talk by Dr. Isa, to understand the surgical anatomy of the aortic valve and to avoid the commonly injured structure during aortic valve replacement. So this is a cross section of the heart. We can see the anteriorly the aorta and onto the mitral valve leaflet on the left, and the tricuspid valve on the right of the screen. And we need to appreciate the aortomitral valve leaflet and the continuity between it beneath the non-coronary and left coronary cusp, and appreciate also the location of the membranous septum and the conduction system beneath the non and the right coronary cusp. And we need to also identify the right and left coronary ostium. Moving to sizing of the aortic prosthesis, the valve chosen must fit properly into the annulus, and 3 simple sutures are usually inserted in each commissure. And the aortic orifice can be opened by applying traction of these 3 sutures. And at times, suture placed in the nadir of the annulus between the commissure, it will open the LVOT more optimally and making the sizing easier. And then we can use the obturator provided by each valve, serially introduced the annulus, starting with the smallest one first, and then the correct size prosthesis is therefore selected. Moving to a suture insertion technique, the valve is sewn into the position via interrupted bridgeted double needles with deep bite into the annulus is taken, and suture end are then held and fixed in correct order into an organizing ring or organizer. And once all annular suture are placed, then will be passed in the sewing ring either singly or in a vertical mattress technique. Alternatively, this can be done in one step, annular bite, and then passing it through the sewing ring immediately. One technique to facilitate exposure while taking the bite is by pulling the previously placed suture to bring it to bring out the tissue and facilitate exposure. suture security, the sutures must be individually tested to ensure the security of the bites on the annulus that can tear through if the bite include only degenerative tissue or a narrow rim of the annulus. So if the suture is insecure, then remove it and convert it to a figure-of-8 stitch and then pass it through the sewing ring in a horizontal mattress fashion. Moving to stitching technique, usually we use Bridgeted. Normally we use it to add more security, especially if the annulus is calcific or friable to hold the suture. We have two techniques, everting and non-everting sutures. For everting suture, the Bridgeted is lying above the annulus, so the bite is from the aorta toward the ventricle. This will place the valve in intra-annular position and will result in reduced effective orifice area of the annulus and allowing a smaller valve to be implanted. Another technique is non-inverting suture, with the Bridget remain subannular in position, so the stitch will pass from the ventricular side to the aortic side. By this, we increase the effective orifice area by allowing the valve to sit in a supraannular position and allow a larger valve to be implanted and adding a better security and satisfactory buttressing effect. And the use of Bridgeted suture has markedly decreased the occurrence of paravalvular leak. Another bad complication that can happen when deeply placed a suture near the lung and the right coronary cusp, which is heart block, and this happens when a massive calcification or friable tissue, as in case of infective endocarditis. So if this happened, then temporary ventricular wire are recommended for all patients undergoing AVR. And if the patient is still in complete heart block at the completion of the procedure, then a temporary atrial wire should be placed to allow for AV sequential pacing. And patient prosthesis mismatch, a permanent pacemaker may need to be implanted before discharge if the aortic valve conduction or the AV conduction, has not been re-established during the hospital stay. Another complication is injury to left coronary artery or left coronary ostium. Using a precise site for suture placement into the annulus is often obscured by calcification and deformities. So deep suture near the left coronary annulus may puncture the left main and it pass behind the aortic root. And we must always take all precaution to avoid its occurrence. And to prevent myocardial ischemia and injury, suture need to be immediately removed. And if integrity of left main is jeopardized, then we have to bypass the affected vessel. Moving to suture placement in the prosthetic ring. Suture are passed through the sewing ring from below upward, with the needle exiting at the mid-junction of the sewing ring. And knot should be face away from the orifice of the mechanical valve and preventing the contact with the disc or leaflet. So from down up and from mid away. Moving to seating the prosthesis. Once all suture are placed in the sewing ring, then the prosthesis is gently lowered and fitted in the annulus. And we have to keep irrigating the suture with saline, allowing the suture to be pulled through the sewing ring more smoothly. One of the issues when seating the aortic valve that are encountered during aortic valve surgery is having a narrow sinusoidal junction. And when the sinusoidal junction is narrower than the aortic annulus, then the appropriate size prosthesis will be too large to pass it. So the holder is removed, and then the prosthetic low-profile valve is turned on one end, then lowered down and seated safely in the aortic annulus, as shown here. Having obstructive element is also very important to ensure that there is no redundant tissue fragment, calcium, or subannular platelets that protrude into the LVOT, preventing satisfactory opening and closing of the valve. A normal valve function must be ensured, and any obstruction element should be removed before final anchoring of the prosthesis. For direction of tying after satisfactory seating, the suture tied down securely parallel to the direction of the sewing ring. And tying down across the prosthetic leaflet may traumatize the leaflet tissue or the prosthetic valve through contact with suture material or surgeon's fingertip. Having a long suture's end, one also need to check the prosthetic function and verify an obstructed opening and closure. And after tying, usually we tend to cut the thread short to avoid any knot to be directed toward the sewing ring. Moving to aortotomy closure, and it's usually accomplished using continuous furrow Prolene in a double layer fashion, and starting at each end of the incision, and suture then tied on each other anteriorly. And to avoid bleeding from the end of the aortotomy, then bites of the unincised aortic wall, or take few bites behind the start of the incision, or simply use a bridged suture at each end. One of the complications that might happen during aortic valve replacement is coronary air embolism, which does occur during the evacuation of air from the LV, and every preventive precaution should be taken, starting from decreasing the pump flow and RCS temporarily occluded with digital pressure. Also, aorta is partially unclamped to allow blood mixed with air to be trapped in the aortic root and to flow freely from the vent opening on the aortotomy. And also by using a high suction to a vent needle in the aortic root to continuously remove any air bubble that may be ejected when the heart is being filled, and then ventilation is started. And only when all air has been evacuated, and then the vent can be moved and the vent suture is tied down. And usually it's confirmed by transesophageal echo. Having a friable and weak aortic wall, it may require a placement of additional reinforcing braided suture, especially if the aortic wall has been denuded of its adventitia, or if the aorta is thin-walled or friable. And aortotomy suture line can be reinforced with strips of autologous pericardium. For closure of oblique aortotomy, the closure in this case would start before the valve is seated, and starting at inferior extent of the opening into the non-coronary sinus and then tied. Suture line is continued for 5 to 6 bites and is left too loose and tagged. And then the prosthesis is then seated and valve suture securely tied. and the aortotomy closure suture is tightened and continued to completion. Moving lastly to patient prosthesis mismatch, which refers to prosthesis valve that's functioning normally, but having an effective orifice area that is too small in relation to patient body surface area, and therefore the cardiac output requirement. So by having a mismatch between the patient body surface area that demonstrate and require a specific cardiac output, the prosthetic valve with a specific size and effective orifice area. The effective orifice area is a flow-dependent parameter, and it's usually calculated from the continuity equation by Doppler. And to classify a prosthetic valve mismatch, we tend to calculate what's called the effective orifice area index, which is calculated by dividing the effective orifice area of the prosthesis used over the patient body surface area. And we have three categories from mild to severe. Mild, when you have the effective orifice area index of more than 0.85 centimeters square per meter square, moderate between 0.65 to 0.85 centimeters square per meter square, and severe in case of effective orifice area index of less than 0.65 centimeters square per meter square. And this table is usually provided with each prosthesis company, and it's customized for each valve, and supposed to help us in selecting the proper valve size with the optimal orifice, effective orifice area to prevent patient prosthesis mismatch. Here we can see in the left side the patient body surface area, and on the right side of the table the size of the prosthesis, and we are aiming always for the green side of the table to avoid patient prosthesis mismatch. This was the end of my presentation, and these are my references. Thank you all for listening. Any question or comment?
Thank you, Khalid, for this informative talk. Is there any question or comment for Khalid?
Assalamu alaikum. Can you hear me?
Yes.
الله يعافيكم دكتور محمد ينتظر يعطيكم البرزنتيشن في مجال يبدأ immediately لأنه he's limited and he's presenting from Canada, so if we can do this immediately that would be appreciated. Thank you.
So thank you, Dr. Mohammed, for joining us. I know you have limited time, so maybe we can start with the case discussion, and later on we'll continue our presentation.
يعطيكم العافية شباب. السلام عليكم جميعا.
هلا دكتور. وعليكم السلام.
أنا كتبت صباح الخير لأنه عندنا الصباح إن الساعة 7 فالمعذرة منكم. Unfortunately my time is really limited عشان بعد ساعة I have to go to the operating room. I prepared few slides بس ما شاء الله Khalid presented almost everything, so I expect you guys already knowledgeable about this topic. My case will be a little bit different. It will be mostly interactive. But before I start, I wanted to thank Dr. Mariam and Dr. Farid على invitation. I really appreciate it. As I said, it's going to be interactive. I would really appreciate if you guys can participate, and I don't want to call names, but if you guys don't start talking, I'll probably have to call names to start. Can you guys see my slides?
Yes.
Perfect. Okay. So who's gonna take the lead and start? I need somebody PGY 3 for intermediate resident. Okay. Ziad, can you hear me?
Yes.
يلا زياد ابدأ.
Okay. 65-year-old female presented to your clinic complaining of shortness of breath. She comes with an echo report showing aortic stenosis.
ممتاز. So she comes to your clinic. This patient is 65-year-old. What do you want to do?
I will take history. I will do examination. I will
Perfect.
do
Quick history. So what do you want to ask her?
I will ask her about symptoms, when it
Perfect.
started, how it's progressing through time.
So started for the last 6 months. So
Progressing.
I'm your patient. You can go ahead and ask me.
Okay, what's your symptoms other than shortness of breath?
So it's mainly shortness of breath.
Since when? 6 months, you said.
6 months.
Progression with time.
Yes, getting worse for over time.
Okay, any other symptoms? Any fatigability, cyanosis,
Yeah, I
syncopal
feel
attack?
all the time.
What you feel? What?
Fatigue.
Okay. Any other symptoms than these two?
Like what?
Any syncopal attack? Any palpitation, chest pain?
Okay. No, nothing.
Okay. Any? Do you have any chronic disease?
Yani you moved on to past medical history. So anything else in the symptoms that you want to ask?
I will, like I said, I will ask about fatigability, symptoms of poor perfusion to the circulatory, like fatigability, syncopal attack,
Perfect.
like that.
How about paroxysmal nocturnal dyspnea and orthopnea, lower limb edema? Very important, صح?
Yes.
So if you think about it, there are 5-6 symptoms that you all have to think about. Shortness of breath, on exertion, orthopnea, when they're lying, how many pillows do they use to sleep? Paroxysmal nocturnal dyspnea, lower limb edema, feeling bloated or gaining weight, which is a marker of heart failure. Palpitations, syncopal, pre-syncopal episodes, those are the main important questions. Then you move to the non-specific, fatigability, loss of energy, and so on. Right, perfect. Thank you, Ziad. Rami? Rami, do you hear me?
Yes. Yeah.
طيب. Not all patients with aortic stenosis are symptomatic. Some of them are asymptomatic, but they get diagnosed by chance from their family doctors, from family friends or whatever. So how do you deal with asymptomatic patients coming with diagnosis of aortic stenosis?
You mean from site of examination or?
No. If the patient is asymptomatic patient with aortic stenosis.
We need to do periodical follow-up for this patient.
Agree. But how would you make sure that the patient is not symptomatic? It's on the slide.
We make sure about the sign and symptom of this patient.
Okay.
We need to look for echo parameter of this patient, and we see periodically how it's affecting in periodic period. And we can do some exercise, some exercise test for this patient to see if they become symptomatic during exercise or not.
Exactly. So this is my point. Not all asymptomatic patients are actually asymptomatic. Some of them, they have so much symptoms that they tend to do nothing and become very quiet, and their symptoms will disappear. But when you stress them, get them to walk or put them on a treadmill, the symptoms will start to appear. Okay.
Yeah.
So you have to consider stressing patients to elicit if they have any symptoms. Okay. So back to when Ziad mentioned the symptoms, mainly symptoms of heart failure, angina, or syncope. Nora, why do you think patients with aortic stenosis might have angina? It's not coronary artery disease.
Could it be obstructing the blood supply to the coronaries by having just a stenosed valve?
Okay. Can you elaborate more?
Or I'm thinking, so aortic stenosis would cause LV hypertrophy, concentric, because of the pressure overload. So
Yeah.
another possibility, I'm thinking about the hypertrophy of the ventricle. So there is a mismatch in the supply and the requirement.
Absolutely. So there is an increase in demand because of the hypertrophied muscle. And at the same time, there is decrease in supply because of the aortic stenosis. There is not enough blood going back during diastole to the coronaries, okay, because of the stenosis. And the same thing applies for the syncopal and pre-syncopal episodes, right? Because there's not enough blood going to their brain with every ejection, so there is a decreased supply. Okay, perfect. Subtle symptoms we talked about as fatigability and loss of energy, but there are also very rare symptoms that can present with aortic stenosis. Mohammed Al-Matlaq. Mohammed? Okay. Anwar?
نعم.
Have you encountered any patient with aortic stenosis who have GI bleeds?
No, I did not have encounter any patient, but
Okay.
I read about it.
Perfect. So why do you think patients with aortic stenosis might have GI bleeds?
I think due to angiodysplasia of the GI tract.
Perfect. And how do you think the angiodysplasia occurred?
I think due to low stroke volume, so there will be ischemia to the bowel, so there will be an angiogenesis or something like that. I'm not sure about it.
That's a good thought. So maybe there is a little bit of decreased supply, but decreased supply would not create angiodysplasia. Anybody else know why there will be angiodysplasia on patients with GI symptoms with severe aortic stenosis? Abdulaziz? Abdulaziz Jahayi. طيب عبير الغامدي.
Doctor, does it have anything to do with the I don't know, shear forces or so affected dynamics because of so it would affect Okay, I don't know, to be honest, but I'm trying to think here.
I think you're in the right track. When you have severe aortic stenosis, the aortic valve is distorted, okay, heavily calcified. So whenever blood crosses that aortic valve, the von Willebrand factor of the blood gets destroyed, okay? And this will create this angiodysplasia, and they tend to bleed more, okay? It's just an interesting. Are you aware of the syndrome that is called for this particular problem?
No, I don't.
It's Heidi's syndrome, okay? They like to ask this in gastroenterology. Heidi's syndrome, H-E-D-E-Y-S syndrome. Okay, let's move on. So what's the natural history of aortic stenosis? Let's say that 65-year-old that came to your clinic is actually not interested in doing anything, and she asks, if she does not do anything, what would happen? Hani? Hani Barnawi? طيب تسنيم. So Tasnim, what do you think would happen if the patient doesn't do anything, does not get intervened on with severe symptomatic aortic stenosis?
The patient will have left ventricular failure and will have progressive symptoms, symptomatic angina and heart failure symptoms.
Okay, so they ask you, how long do you think will be able to live? How long?
Not sure. Maybe.
Have you seen this graph?
It depends on the symptoms. The mortality or survival will be plateauing until she develops symptoms. We start to have angina. The expected survival will be 5 years, and syncope will be at 3 years, heart failure 2 years, and if they develop on top of that atrial fibrillation, it will be within 6 months.
Mumtaz. The correct way of putting this is that whenever the symptoms start, which is around here, 50% of people who develop angina will live for 5 years. 50% of patients who develop syncope will live 3 years. And if they have congestive heart failure, the 50% survival is 2 years. Okay?
Okay, thank you.
Mumtaz.
Doctor, doesn't it have to do with the severity? I mean, is this fixed for like majority or like I know we rely on, for example, the calcium load, the background, maybe history of the patient, comorbidity or not. So is this taken in consideration everything the comorbidities and different ages, different characteristics of patients?
Yeah.
For this graph.
Good question. I'm not sure, but I think this is about all comers, patients with aortic stenosis. I'm not sure if it's based on the STS database, but it's for all comers, despite their past medical history or comorbidities. But good question. Moving on, we talked about shortness of breath on exertion. It's very important to know the NYHA classification. And I'm sure all of us know that. Can anybody remind us of the 4 classes of NYHA? Firas?
So
Wa alaikum assalam wa rahmatullah. Firas, what are the classes of the New York Heart Association for shortness of breath?
نبدأ بأربعة severe symptoms without exertion. 3 if there
يعني
is
at rest you mean
كده
at rest مظبوط okay
ويقل ما كده 3 يصير on minimal exertion. 2 in exercise and 1 تقدر هنا heart failure بس ما في symptom.
صحيح. So class 4, as you said, there is symptoms at rest. Okay, doing nothing, the patient feels shortness of breath, which is the most severe. Class 1, there is no limitation of activity. They can do strenuous activities without getting short of breath. Class 2, they have slight limitation. So they can do some activity, but if they push it a little bit, they start to get symptoms. Class 3 is marked limitation. So whenever they do anything, even walking inside their household will get symptoms. So this is the difference, okay? It's very important to quantify exactly how much symptoms does the patient have, okay? Okay, so let's move on. Faisal Al-Ghamdi, R5. Faisal, what are the signs of aortic stenosis when you examine your patient?
Depend on their clinical status. If they already have become symptomatic, they will have the obvious signs of heart failure. I would look for that. And there are more subtle signs clinically. But first, on auscultation, they would have a systolic, hollow systolic ejection murmur on the second intercostal space, the right second intercostal space. This is on auscultation.
So on auscultation, what kind of murmur you said? Systolic?
Yeah, on severe stenosis, systolic, yes, systolic ejection murmur.
Perfect. Okay, ممتاز.
And there are subtle signs, and they will have pulsus tardus, weak pulse. They will have other also rare and subtle signs like quincke pulse and Democy sign. Quincke pulse, I think it's when you see pulsating fingernail, you'll see the pulsation on the fingernail. Sorry, quincke pulse is the pulsating uvula. And Democy sign, I remember the name, but I cannot differentiate between them really. But pulsus tardus.
So just to correct you, Quincke sign will, and the other signs you mentioned, those are mainly for aortic insufficiency, right?
Sorry, that's my mistake. Yeah. So it's mainly the murmur and the heart failure symptoms, the heart failure signs that you would see. That's it.
Perfect. ممتاز. أنت قلت the most important ones, which is the systolic crescendo decrescendo, which peaks in the middle between S1 and S2, and the radiation is mainly to the carotids, right? Delayed carotid upstroke is another one. You can, if you put your stethoscope on the carotid, you can hear the pulse slightly later than what you would expect. And pulsus parvus et tardus, which means that the pulse is small in amplitude and late, okay? And this is because of the delayed ejection systolic time. It takes the heart longer time to produce systole, which makes it small and late. Okay, so patients, going back to the case, the patient came already with an echocardiogram showing severe aortic stenosis. Let's move on to Khulud. Just trying to make sure that I involve everybody. Khulud, can you hear me? No? Okay. Isa?
Yes, doctor.
Helena Isa. Isa, what are the echocardiographic signs of aortic stenosis that you look for on echo reports?
We will see the aortic valve area.
Okay. So what's the cutoff of aortic valve area to call it severe stenosis?
Severe stenosis less than 1
Less than 1 what?
square centimeter.
Meter square. Mumtaz. What else?
Mean pressure gradient.
Okay. And how much of a gradient?
If it's more than 40 millimeter mercury, we consider it severe.
Mumtaz. What else?
Aortic jet velocity.
Okay.
If it's more than 4, we consider it as severe.
For what?
Millimeters in the second.
Meter second. Okay. And it's the peak velocity, not any velocity. Okay.
Yes, peak velocity. Yes.
Velocity. My point here is that we almost all know the numbers, but we tend to forget the units, which is very important. Centimeter square, meter per second, millimeter mercury. Okay. Good, Ace. Mumtaz. طيب, moving on. Hammam. Hammam al-Bashir. Okay, not with us. Abdul Karim.
السلام عليكم.
وعليكم السلام. كيف الحال؟
الحمد لله بخير.
عبد الكريم, قبل شوية سمعنا in the previous lecture the most of the guidelines for valvular heart disease. How do you put patients with aortic stenosis? What are the stages of aortic stenosis?
طبعا عندنا في الجايدلاينز عندنا اللي هو most of the valves عندنا اللي هو ال A وال B وال C وال D.
مظبوط. So what is A? What is stage
ال A اللي هم at risk for aortic stenosis. غالبا يكون عندهم some sort of valve anatomy that just puts them at risk. And then B is progressive, C is severe asymptomatic, and then D is severe symptomatic.
Perfect. مظبوط. Thank you. So A is at risk. Patients who have bicuspid aortic valve, who's known to have that aortic valve sclerosis, they have something that makes them at a higher risk of developing aortic stenosis. B is progressive on multiple measurements. So on serial echoes, you can see that there is slight deterioration of the hemodynamics of the aortic valve. C is asymptomatic severe. And D is where symptoms start. And symptoms usually do not start unless it's severe hemodynamic aortic stenosis. But then we have multiple different stages under symptomatic severe aortic stenosis. So D1 is the symptomatic severe with a high gradient, where it meets what we just mentioned, the 40 millimeter mercury mean gradient, the 4 meters per second peak velocity, the area less than 1 centimeter square. But it gets more complicated when we talk about low flow, low gradient people, okay? So probably this needs a talk by itself, but just to summarize it quickly, patients with low flow, low gradient, they present with hemodynamic changes on aortic valve that does not meet the severe aortic stenosis that we know about, but you still have high suspicion that those patients are having aortic valve stenosis. So let's talk about the classical low flow, low gradient patients, which is D2. Those patients present with aortic valve area less than 1 centimeter square. So this is one of the markers, but again, it's not the most specific. You look at their gradient, the mean gradient is less than 40, and their velocity is less than 4 meters per second, but you have still high suspicion. You look at their ejection fraction, and it's low, less than 50%. So in that situation, those patients are entailed to have a dobutamine stress echocardiogram. So you stress them with dobutamine anywhere from 5 to 20 mics per kg per minute. And you see how that left ventricle interact with this amount of stress. So if the ejection fraction increases and you can demonstrate that there is enough gradient to exceed 40 millimeter mercury, or velocity becomes higher than 4 meters per second, while the area is still less than 1 centimeter square, means that this patient actually has severe aortic stenosis. And the explanation here is that this low ejection fraction, this heart is unable to produce enough gradient across the valve during each systole. So you need to help it with dobutamine to demonstrate that. It gets even more complicated with patients with symptomatic aortic stenosis when their ejection fraction is normal, more than 50%, but their gradient is less than 40 and their velocity less than 4 meters per second. They have the area of less than 1 centimeter square. They have a normal ejection fraction, but the gradients are still not severe enough. And the explanation in those patients is that they have an extremely thick ventricle and very small LV cavity. So during diastole, when the ventricle fills with blood, it doesn't have the space to fill enough stroke volume to elicit a gradient with each systole, okay? And this is called the restrictive pathology. So it's like a restrictive cardiomyopathy. The ventricle is too thick. So in those situations, you don't have to do a dobutamine stress test because the ventricle is normal. But what you have to look at is the stroke volume index. Stroke volume is the amount of blood leaves the ventricle with each contraction. So you index that amount to the body surface area of the patient. And if you have less than 35 mLs per meter square, because it's indexed to the body surface area, it means that this patient has a paradoxical low flow, low gradient. So D2 is called classical, and D3 is called paradoxical low flow, low gradient. But it has also more variations if you dig more into the patients with low ejection fraction, because some of those patients have different reasons to have low ejection fraction, like coronary artery disease, or their ventricle has been burned out because of prolonged state of aortic stenosis. Okay, so let's move on to the recommendations for aortic stenosis. I know that in the previous lecture that was presented by Khalid, he mentioned all about it. So let's just go quickly. I'm going to use another body. Abdurrahman Al-Ruwaili. Abdurrahman, can you hear me? Okay. So who wants to take the next question? It's very easy.
It depends on the question.
Okay. The question is, what are the class 1 indication for intervening in aortic stenosis? Class 1 recommendation.
Me?
Yeah, who's going to take it?
Can I answer?
Okay.
Yeah, of course.
Severe asymptomatic AS and severe symptomatic, AS, And patients who are asymptomatic can have severe AS per echo, but they have to have reduced ejection fraction or other indication for cardiac surgery.
Concomitant cardiac surgery. مظبوط. تمام. So you mentioned severe symptomatic aortic stenosis, severe asymptomatic aortic stenosis with reduced LV function, ejection fraction less than 5%, or patient going for another concomitant cardiac surgery. ممتاز. The new guidelines اللي Khalid just presented added 2 more points for class 1 recommendation for aortic stenosis.
It was regarding the low flow, low gradient, and the low flow state, the D2, D3 stages of aortic stenosis.
Exactly.
You have just to confirm that it is the reason for their symptoms is the severe AS. Once you are sure, you can take them for surgery, I think.
100%. ممتاز. Because those 2 points, they've been added or changed in the most recent guidelines, D1 and D2 and D3. So if you think about it, all the symptomatic severe aortic stenosis, they need to have some sort of an intervention, whether they're classical, paradoxical low flow, low gradient, or the normal hemodynamically significant severe aortic stenosis. When it becomes asymptomatic, it becomes a little bit trickier. So low ejection fraction, less than 50%, or other concomitant cardiac surgery. Mumtaz. So another person to answer the next question, which is going to be a little bit more difficult. The question is going to be, what are the indications to operate on a patient with asymptomatic aortic stenosis? When would you guys offer surgery for a patient with asymptomatic? It's here. Fatma Al-Hijab.
هو basically an anura. Basically, if the patient requires any surgical intervention, cardiac surgical intervention, then that would be indicated regardless of the severity. Another thing, also we look at, according to what's mentioned here, if there's a rapid progression or BNB more than 3 times the normal, or Vmax more or equal to 5 meters square, 5 meters per second, then we could offer them surgical AVR. That's class 2A. And for other cardiac surgery as like concomitant, this is would be class 2B.
If it's moderate.
Yes.
It's moderate. So very important to know the class 2A indications for aortic valve stenosis. So first of all, patients with exercise tolerance test that is abnormal, okay? Abnormal exercise tolerance test does not mean that the patient gets symptoms, because if the patient gets symptoms, they already directly goes to the symptomatic part of this graph, and they get the class 1 indication. But if their blood pressure drops more than 20 millimeter mercury or 20 points during the exercise tolerance test, it means that it's abnormal. Or if they have decreased exercise capacity. And in that situation, by itself, they meet the class 2A indication. Critical aortic stenosis, which is defined as 5 meters per second peak velocity, is by itself a class 2A indication. And this is based on a New England paper. I think it was called the Recovery Trial, if I'm not mistaken, where they studied patients with severe asymptomatic aortic stenosis, and they compared between going into early surgery versus observation, and they found that there's statistically significant benefit of operating early. So that this is where this comes from. The BMB, which is a new addition to the guidelines, if it's more than 3 times than the upper normal, then you can consider operating on patients with severe asymptomatic aortic stenosis. Rapid disease progression on multiple serial echoes. If all those patients have low surgical risk, you can operate. It's very important to notice that on the class 1 indication on the left-hand side, aortic valve intervention, they kept it very broad to include surgical valve and TAVIs, okay? But when it comes to the class 2A indication, it's only the surgical aortic valve replacement that is recommended because they don't, or we don't have enough data to support TAVI on this patient population, okay? So it's only SAVR here. Going to class 2B, which is a little bit different, those patients, if you have a moderate aortic stenosis, so your peak velocity still did not reach 4, your gradient did not reach 40, you're going for concomitant, let's say a CABG, for example, they downgraded operating on that aortic valve to class 2B. And it used to be class 2A recommendation. Now it's class 2B. And this just to support or to be in favor of doing TAVIs for those patients down the road. So this is very important. Last but not least, patients who have normal ejection fraction and their EF still is deteriorating, but still has not reached the less than 50% cutoff, where it meets the class 1 indication, but it is progressively getting worse on multiple serial studies. At that point, you can argue that those patients' ventricles are deteriorating quickly and doing an operation on them might be of benefit. So it's class 2B. Any questions about the guidelines?
No.
Okay. So when would you operate on asymptomatic aortic stenosis? We already mentioned that. So let's go back to our case. Our 65-year-old lady who was having some shortness of breath. She came with an echo report showing severe symptomatic aortic stenosis. We said this is a stage D1, and based on the guidelines, she meets the class 1 indication for surgery. Then comes the important discussion about the choice of intervention on these patients. That by itself on the guidelines is a very important paper because there are so many information that you can obtain, and I'll shed light on the surgical aortic valve part. I think TAVI deserves a talk by itself on another day. So the management option is based mainly on the patient age, okay? So if the patient is less than 50 years of age or less than 65 years of age, you can argue that the surgical aortic valve is the way to go. Patients population who are less than 50, mechanical aortic valve replacement is still recommended as class 2A in comparison to bioprosthesis. Patients between 50 and 65, mechanical or tissue, either or, they're both class 2A, and more than 65 years of age, bioprosthetic valves is class 2A. The Ross procedure, which is the pulmonary autograft in the aortic position, although we have lots of data from North America about the Ross procedure in young adults, still hasn't made it strongly to the guidelines, and it's still stated as class 2B in a center of expertise. So it's still not that strong. So if the patient has no contraindication to have warfarin therapy, then you can discuss the mechanical versus tissue valve. Okay, so our patient is 65, so she's kind of in this patient group between mechanical and bioprosthesis, and for that reason, we all know that each of those valves have their own pros and cons. Okay, but we don't have the ideal perfect valve. The ideal valve is the valve that would last with the patient for the longest period of time. It's the valve that would not require any sort of anticoagulation, and the valve that would not degenerate with time. So we don't have that valve available in the market, but the nearest we got is the Ross procedure. And the Ross procedure, it's very controversial because you're operating onto two valves and you're changing the problem from one valve into two valves. But there have been lots of papers that have demonstrated the longevity of patients who receive Ross procedure that is comparable to the age and sex matched population in patients less than 60 or 65 years of age. So again, this was presented in the previous lecture. It's a shared decision-making between the patient and the surgeon. It's very important to rule out any contraindications for blood thinners. Then if the patient is less than 50, class 2A, to go with the mechanical prosthesis, more than 65, more into the bioprosthesis. If in between, you can discuss either. So, so this patient is a good candidate for a surgical aortic valve. You explained to her the tissue versus mechanical, and she wanted to proceed with the tissue valve. So can anybody tell me how's the consenting goes between you and the patient? What would you tell the patient going for an aortic valve replacement? What are the risks of this procedure?
Okay, so usually we start with general surgical complications, so bleeding, infection, thromboembolism, AKI, those sort of things. Now we do sometimes do the risk stratification, but from my own experience as a junior resident, I feel like the more I tell them, the more anxious and stressed they will be. Sometimes they wouldn't even, they would delay signing the consent and wait until admission. So for me personally, I keep it short. I give them the paper to read it. I mention everything, and yeah, that's for me what I do. I don't know about the rest.
Can any of the senior residents comment on this?
I disagree actually with this hiding the complication from patients.
So what approach, Faisal? What do you do?
Well, when I consent any patient, I am honest and frank. I tell them scientifically all the possible complications, which I will tell after I finish my argument. But I will tell them the complications and the possibility of them happening. And I would discuss with the patient when they feel like they are becoming hesitant, that the only reason they are going through this risk is because the risk of them suffering from the complication of aortic stenosis is higher. So they are risking with these low complication, if they are truly low risk, in order to be recover from AS and avoid the inevitable consequences of aortic stenosis, which we already said that once they become symptomatic, it's already almost too late. When they have angina, they are 50% of them die in 5 years. When they have syncope, 50%. When I tell patients like this, I tell them that you are risking these 2 or 3% mortality rates for the sake of avoiding dying, being one of the 50% who will die in 5 years. Usually they agree. And it is also you protect yourself. I mean, the patient, if he had a complication, might not say anything, but his relatives will come to you and tell you, why did you not tell us this thing?
That's why you're giving them the paper to read, and you're making sure they understand and signing everything after reading and knowing everything. I mean,
some patients, when you tell them
every single complication,
Mhm.
yeah, you don't need to go through every single complication. They will get scared. But if you give them the paper, they read. They are literate.
It is natural for them to be afraid. For me, when a patient becomes afraid, I tell them, I would be afraid if I was in your place. But you are going through this risk just to be healthy afterward. If you don't do, eventually, after Allah's will, you might not survive, or you'll have the worst life. What would you choose? And then he has the right to choose. We are not the one who decides for our patient what should they do. They are the one who choose.
Yeah, of course. Autonomy.
Actually, I agree with both of you. I think Nora has a point that patients get scared, and I think this is because we as surgeons tend to try to rush things very quickly, and we just want them to sign that paper so we can move on. We have other patients to see, and clinic full of patients. We have to go back to the operating room. But spending the extra 5 to 10 minutes would make all the difference. If you think of this patient as a family member, you would sit down with them and talk to them. So my advice to all of you is that, and this is something I do personally, whenever I want to talk with the patient about a consent, grab a chair and sit down. You need to sit down, and you need to allocate that 5 minutes for the patient to explain to them in details, because for you, it's just another day in the operating room, but for them, it means a lot. Maybe this is the most or the scariest thing that they're going through. You can't even start to imagine how tough this is for the patient. So spend the time, sit down with them, talk to them for 5 minutes. It might seem very long, but if you explain, as Faisal says, if you explain exactly what we discussed in this lecture, the natural course of the disease, if not intervened on, and what would they expect, okay? And you also give them what are the risks, and make sure to put numbers to the risk. People understand the numbers. If you tell them that they might die from their surgery, they would say, why should I go for surgery if I might die? But if you tell them that this is 1 to 2% risk of mortality, which is based on data, then you're telling them the truth. But there is, on the opposite side, there's 98% risk of surviving this operation. So you give them the number, you give them the perspective about this number. When you tell them that you might have a stroke because of the surgery, that's true. But it's what, 5-6%. So there's 94-95% risk of surviving this operation without having a stroke. And this is exactly what I tell the patient. So bottom line, take home message is that spend the time, put your watch for 5 minutes and sit down with the patient, talk to them, answer their question, let them repeat what they understand from you, then let them sign the paper. That paper is very scary for the patient and very intimidating. So you have to facilitate things, break it down, give them a little bit of time, and they would really, really appreciate it.
Muhammad, can I add something?
Please.
I think the surgery would be even scarier for a cardiac surgeon. If we had to sign this consent, we know the complication of every step. I mean, I think the patient's position is even better. Their ignorance is a bliss for them. If we understand this, I really do what I just said. I spend with the patient time and I try to understand their position. They're going through toward the unknown, and you are supposed to be their guide.
I agree 100%. Exactly. Okay, so planning stage, you guys already talked about the patient prosthesis mismatch and how to calculate the effective orifice area so I don't have to repeat that. Basically, just to quickly go through it, patient-prosthesis mismatch, it means that you create iatrogenic aortic stenosis if you put a prosthesis that's smaller than the patient's size, okay? And you calculate the risk of PPM by dividing the effective orifice area of the valve that you're gonna choose based on the chart, and you divide it by the body surface area. So let's say if you have a petite 80-year-old lady who's short and slim, and you put a 19-millimeter prosthesis, it's different than putting the 19-millimeter prosthesis, which has the same effective orifice area, on a big, tall guy. Okay, so that's how you think about it. Smaller patients might tolerate smaller valves, but bigger patient, you need to be very careful. Having said that, with all the argument of the patient prosthesis mismatch, it's still very controversial, because some people would argue that those patients, especially elderly patients, may not be that active to generate or to produce gradient across the prosthesis that would elicit the patient prosthesis mismatch. So they are already not active enough to show. So you might decrease the risk of the operation by doing extra stuff and just go ahead and put a smaller valve. So it depends on how you think about it. But bottom line, what I personally think is that bigger valves are better valves, and they would definitely serve the patient and do them better. So back to our case, patient's dimensions were 175 centimeter, weight is 85 kilograms. So you do a little bit of calculation, as you can see here. You can calculate the body surface area based on the height, weight, and you divide them by 3,600. Then you take the square root, and you get the body surface area, or you use your app on your phone and you do that quicker. You take that body surface area. So let's say that this patient has BSA of 2, and you go to the chart of the valve that you might use, okay? Looking at those charts, it depends on the company that makes the chart. So Edwards, for example, did that chart for the Magna Ease valve, and you can see that most of the chart is green. They just want to advertise their valve as a good valve with a low risk for patient prosthesis mismatch. But if you think about it from a body surface area of 1, I've never seen a patient with a body surface area of 1. So everything from 1 to 1.5 is probably nothing. It starts from 1.6, 1.7 and forward. So that's a small point. You look at the effective orifice area, and you divide it by the body surface area, and you get a number. And this number represents the risk of PPM. So anything below 0.65 centimeter square per meter square, because it's indexed, this considered severe patient prosthesis mismatch. Anything between 0.65 and 0.85 is considered moderate. Okay, so let's say that this patient has a BSA of 2. If you put a 19-millimeter Magna Ease tissue valve, you're going to have an effective orifice area index of 0.8. And this is considered moderate. That's why it's in yellow. So you better put something bigger, going 21 or more, if possible. Okay, so let's do this case quickly. I might have to go in 15 minutes or so. So who wants to do an aortic valve replacement? Just going through the steps in the operating room quickly. We need a senior resident for this, maybe a PGY 6 or 7 or 5. Any takers? Who's the chief resident? It's just an AVR. Straightforward.
Can I try?
Please. I appreciate it. Thank you, Faisal.
Okay, so to plan for my procedure, my incision will be for this patient would be a full sternotomy.
Okay.
So I will do her through a full sternotomy, and then after doing the sternotomy and the pericardiotomy, I will do my cannulation. My cannulation strategy will be the arterial cannula would be on the ascending aorta, and the venous cannula would be a dual stage single venous cannula in the right atrium. After cannulating the patient, and after cannulating the patient, I will use antegrade myocardial protection cardioplegia, but it would be direct into both ostiums. But she does not have AI, but I would need to do the aortotomy. Yeah, so it would be direct. Once cannulated and putting the cross clamp, I will do my aortotomy. First, it will go through. This is the part where I always forget. I would first do my with the 11 blade. I will open the aorta, extend my aortotomy toward the non-coronary sinus. Once I can see the aortic valve, I will go horizontally on each side toward the left coronary and the right coronary sinus to expose the aortic valve. I will use for this patient blood cardioplegia, direct in both ostia. Afterward, I will start the aortic valve replacement. First, I will remove the leaflet. After removing the aortic valve leaflets and decalcifying if there is any calcium, I will put my stitches. I will do them interrupted, pledgeted suture. It will be everted, so the pledget will be toward the aorta itself, not toward the LV. So it will be horizontal matrices with the pledget on the attachment line of semilunar attachment line of the aortic valve leaflet.
So
and then
you just to understand, everting means that the pledget will be in the aorta, not in the ventricle.
Yeah, it's on the aorta.
Okay.
Yeah, and afterward, after sizing the valve and putting the proper size of the valve and placing the valve down, I will close my aortotomy and put an antegrade cardioplegia cannula in case I will need it. And then I will start, but before closing the aortotomy, I will de-air the LV through after closing the aortotomy, I will de-air the LV through the cardioplegia cannula that I have placed after closure. And then I will start the process of decannulating the patient.
Mumtaz. Okay, so excellent, Faisal. Mumtaz. I have a few questions or comments actually. So how would you arrest the heart initially? You said during you're going to put direct coronary ostia, so?
Yes, yes.
What are the other options?
The other options, I can put I can put the cardioplegia catheter. That's another option, but it will hinder my aortotomy, and I think I should not use it. Another thing I can, if I want to be to protect the heart very well, I can do cool the patient. But this is a very short procedure. I will not cool her because of the side effect of cooling the patient until she fibrillates, and then I will open and give her the ostial direct cardioplegia. These are the options to arrest the heart. Either cardioplegia through any way you want, technique you would give, or fibrillating, then giving the direct cardioplegia.
Okay, yeah, exactly. There are so many ways of doing it. Okay, you can start with the antegrade cardioplegia. If you cannulate your aorta a little bit higher, the proximal arch, you would have plenty of space to do your aortotomy and at the same time put your antegrade cardioplegia needle in the ascending aorta away from that aortotomy line. Because where would the aortotomy line be? Where would you start your aortotomy?
I don't know really. I don't have an answer. Actually, maybe above the fat pad of the aorta.
Yeah, but the fat pad is different between patient and patient, right? So you want to avoid injuring the right coronary artery, and you want to be above the sinotubular junction. So anywhere 1 centimeter, you can palpate and feel where is that coronary, and you always can start slightly higher. Then you extend your incision down to the non-coronary sinus. So start higher with your aortotomy, with your 11 blade, extend it a little bit with the Metz scissor, put your suction in, vent the heart, visualize where is the aortic valve, then extend your aortotomy as a J shape, okay? You can always start with antegrade cardioplegia. If the heart is not arresting or the ventricle is distending, you always can vent the heart with an LV vent or the root vent, then start again. Sometimes you ask the perfusion to start the cardioplegia fast so they can close that aortic valve and make it competent. Make sure your cross clamp is applied horizontal to the aorta so it does not distort the configuration of the aortic valve, so it does not create an iatrogenic aortic insufficiency. And if this is not helping, you can go ahead and open and do your ostial. So this is important. So cardioplegia for myocardial protection, ice on top of the heart. Some people put that for further myocardial protection. For hypothermia, you can swing the temperature or drift the temperature down a little bit. You can't go wrong with slightly lower temperature. You go to 35, 34.5 Celsius, and you can rewarm while you're closing the aorta. You don't need to go lower than that. You don't need to fibrillate the heart. So those are the 3-4 things for myocardial protection. Okay, what are the techniques for de-airing? You mentioned some of them.
Could you please just recap the 4 techniques?
The 4 techniques for what? For myocardial protection?
Yeah, myocardial protection.
So the cardioplegia itself, which can be given through the antegrade cardioplegia with a stab needle in the ascending aorta, the usual way.
Yes.
You can start the cardioplegia and try to arrest the heart with that. If not, option number 2 is you open your aorta and you put ostial cardioplegia.
Yes.
Down the right and left coronary ostia.
Yes.
Option number 3 is to put your retrograde cardioplegia into the coronary sinus. So,
yes.
So those are the cardioplegia delivery systems. Another option, another thing you can do is you can put ice on the heart and the right ventricle for further myocardial protection. You can drift the temperature down. You can cool the cardioplegia itself. And those are the methods, okay? De-airing the heart after. Faisal, you mentioned that you wanna, did you mention that you wanna put an LV vent or just the root vent?
For this case with the aortic valve, I would only, the aortic root vent would be enough with the guidance of the transesophageal echo. After closure of the aortotomy and before the heart beats, I would ask the anesthesia to put the head down. And then I will ask them while waiting for the heart to beat to do the Valsalva maneuver. And once the heart, during this whole time, I will keep my aortic root vent on, suctioning the bubbles from the aortic root. Then I will wait for the heart to beat. I will ask them for a Valsalva maneuver again. Sometimes shaking the patient could help de-air the whatever air remained there. And with the guidance of the echo, I will look into the LV if there are any remaining bubbles. Of course, during this time, my vent is suctioning all the air. And I will also command my, I will ask my perfusionist to replace whatever he's sucking from the blood. Afterward, once I'm comfortable and the heart is beating properly, I will keep still with the head down. I will remove my cross clamp with the vent still on. I will continue the same technique of Valsalva maneuver and shaking the patient. Once I am sure that the heart is free of air, there is nothing in the LV, I will stop my LV vent. And I will start weaning the patient off bypass.
Yes, exactly. Okay, Mumtaz. That's perfect. Any other questions, guys, about the techniques of doing an aortic valve replacement?
I said that the everting suture for the valve on the attachment lines, most of the surgeons I saw do it, the pledgets are toward the aorta, like everting. Is it possible to do it the other way? And what are the advantages of this one and the other one?
Yeah, good question. To be honest with you, I've never done it everting, always non-everting. So you take your bites from the LVOT up, like from inside out, and you keep all the pledgets under the valve.
Why do you do it, doctor?
So I think the advantage is that it's easier and faster to take your bites this way. The disadvantage is that it might makes your annulus smaller, but it's easier to implant the valve supraannular with the pledgets underneath.
I understand.
Does that make sense?
Yes, doctor. Thank you.
Yeah. So non-everting. The everting, where you put these pledgets outside, is mainly done when you do a Bentall procedure. It's more hemostatic, but again, you will find the angles funnier when you do it that way. But both ways are doable, both ways are reproducible and can be done safely. But it's just a personal preference. Okay, any questions, guys?
I have a question, Doctor. Is it worth putting an LV vent for irrigation and getting rid of the calcium, not only relying on the root vent?
Walid, I think that's a great question, because I worked with surgeons who do not put LV vent, and they just depend on into a drop-in sucker through the aortic valve. But I feel like I was trained to do an LV vent in all the patients through the right superior pulmonary vein. It's better for visualization and better for de-airing the patient. But I'm not sure about the sucking the calcium. So can you tell me more? What do you think? How can you get rid of calcium through the LV vent?
So when you decalcify, sometimes you'll have these small pieces that will not, for example, be picked up by the sponge that you would put in the LV. So after finishing the aortic replacement, I was thinking of irrigating, putting saline, and at the same time working the LV vent. Wouldn't that pick up all these small little pieces of calcium?
Yeah, well, Walid, I will argue with you, because usually when I irrigate the LV, after you decalcify the annulus, I would put the LV vent off, because you want all the pieces of calcium to rise and get sucked onward. You don't want it to go further away from you.
Oh, I see. Okay, makes sense.
There is a way I saw the surgeons in our center do it. They would irrigate the LV after decalcification with water, with saline through the aortic valve. And then they would put a sucker on the left main ostium because it's the lowest. And they will just wash out the LV fully multiple times until they see the water is clean after a couple of times, and that is enough.
Yeah. No, that's a good technique. That's doable.
Doctor, and I have a question.
Fadal.
What did you mean when you said during irrigation you would put the suction off? How would it go away from you?
So think about it. The LV vent comes from the right superior pulmonary vein. sitting into the left ventricle into the most inferior part. So if you keep that suction on while you're irrigating, you're pushing things down away from you. But in my mind, when I irrigate the left ventricle, I want to flush it with saline so all the fragments and the debris rises into the LVOT so I can suction them.
Oh, okay, understood.
In my mind, it makes sense.
Doctor, there is something regarding the tissue valve, and our patient in this scenario will have a tissue valve.
Yeah.
The tissue valve has posts, and you have to make sure that they are away from your coronary ostiums, right? And most tissue valve, you have to align them so you do not block your coronary ostias.
How do you do that, Faisal? How do you?
I will first put my when putting the stitches before through the valve, I will mark my commissures.
Okay.
And then I will start with one of the commissures and I will plan my stitches so each commissure stitch aligns with the post. Is that the correct way?
Yes, I think there are multiple ways of doing it, but this is exactly what I do. So I start with putting my 3 commissural sutures first. طيب. You want to make sure that you visualize both coronary ostia, and this should be the standard of care. You have to see where is that right coronary, and you have to see where's the left coronary takeoff, so you can avoid them, so you can put your pligated sutures underneath them to make sure that they remain patent, okay? I've seen some surgeons actually put a balloon tip cardioplegia catheters inside both coronary ostia. It makes it a little bit difficult to mobilize around the stitches, but they just want to make sure that the valve sits underneath, okay? So put the 3 commissural sutures, then follow with the rest of the annulus. Then when you implant your valve, you take the valve, look at where are the 3 posts, and you start with the 3 commissures. Then you follow and you put it down. When you start tying, you start where the left coronary is, you visualize it, you pick the stitch that is close to it, you tie it down, you make sure that the valve goes down further, then you move to the right, then you move to the nadir of the nun, and you move, you do the rest of the tying.
Clear.
Okay. Sometimes I've seen also some surgeons, they check with a right angle, like a Gemini or something, the patency of the coronary. Okay, so that's very important. So let's say you put your valve in, was very tight space, and you're not sure if the coronary is patent or not. You try to come off pump and the right ventricle fails. Okay, inferior wall is not moving. What would you do?
I have 2 options. The easier one is CABG to the right coronary.
Okay.
And the other is to open the aorta, go back on pump and open the aortotomy and revise my aortic valve and see if I have occluded. But this is another hit to the heart. The heart already took the first with the pump and the ischemia, and then this hit, and then I will give it another hit. So when an old patient like this, I don't know what is the best actually. What do you think, doctor?
I agree with you 100%. So there is no, you have to have all the options in your pocket, and you tailor it to your patient. A patient who already had a long pump run, who's at higher risk, you don't want to open and cross clamp. You're going to have to cross clamp again either way for the bypass, but you don't want to prolong the surgery. You might just go ahead and do the bypass for the RCA. But in a young patient who would tolerate another pump run, you would probably just make the decision, go ahead, arrest the heart, take the valve out, and revise your stitches. But it's very important to keep that in mind. Okay, what other pitfall that can happen? How about patient after an aortic valve replacement, you're trying to come off pump, and you don't have a rhythm underneath, so they have a complete heart block. What would you do?
could be either because of the inflammation around the AV node, or it could be because one of my stitches have already went through the AV node and affected it. So either way, there is nothing I can do other than put pacing wires and hope that the patient recovers after the surgery.
Yeah.
And post-operatively, after 14 days, if he or 10 days, if he's not, if he has not improved, I guess he has to go through to a permanent pacemaker.
Okay, so I have two questions. First question is that where is the conduction system anatomically?
I think it's between the right and the non-coronary sinus, if I remember correctly.
It's not, I think it's, I know it's in there. طيب?
Yeah, it's in the right and the non, yes.
Between the right and none. Okay, good. So how long do you wait before you consult EP for a permanent pacemaker?
This is not objective, like I don't have a study. I know that most of the generally post-operative arrhythmias should recover after 14 days, 90% of them. But in what I have seen in practice, 10 days, you should start thinking about permanent pacemaker.
So would you keep the patient 10 days to make this decision? I don't know, I'm just asking you from your experience.
Yes, عشان for good luck ما أبغى أجيب ال EP بدري ويصير المريض عنده heart block.
For me, I will consult EP earlier, at least if any problem happen with the epicardial leads, they will be aware. And for their evaluation, I saw some cases they implant pacemaker very early because they saw no activity at all in the ECGs.
Yeah. Sultan, I agree with you. I tend to call EP earlier. Day 2, day 3, I would call EP. They put it day 4, day 5, but I wouldn't wait longer, because if I know that sometimes we say it's inflammation or edema around the, but it's most likely it's one of your stitches. Let's be honest about it. And that's
what about putting the leads already while you're in the OR? Putting the permanent leads there, but not not creating any bucket for the generator, just leads. Especially if there was, from the surgery itself, you predict that there will be heart block.
Well, I don't know. Have you seen it done like this? You would do an AVR, you put epicardial lead and leave them.
I vaguely remember a scenario like this, but to be honest, I don't remember the details. What was the procedure and what was? But it's just something that made me think of this kind of option, and when if this is a viable option or not.
I think it is an option, but you have to bear in mind, putting foreign bodies and keeping them for time is always a risk of infection. So unless you really, really need to, I wouldn't do that. I've only done that maybe a couple of times, or seen it done a couple of times in patients with tricuspid valve pathologies.
Yeah, I saw it for tricuspid valve replacement.
Yeah, tricuspid valve, well, a patient already has pacemaker lead and you displace it or something, usually in the right side of the heart, not on the. Okay, good. All right, thank you so much, guys. I really appreciate your participation. I hope you learned something. And if you please have any questions, let me know. I'm gonna also leave my email if you have any questions later on. More than happy to help.
Thank you very much, Doctor.
شكرا دكتور محمد وشكرا دكتورة مريم for arranging the session.
Hey, thank you very much, Dr. Mohammed, for joining us from Canada. We appreciate you joining very early on in the morning. And I like the participation. Usually before we pick in one person to be stick for the whole case, but I'm not sure if you guys find it much more fun to dilute the question among all the student or the resident. So you guys can vote if you want this way to consider next time, or you wanted to go back on the same session before.
it's good to be flexible. So if I know, I will answer. If I don't, then I'm not going to be in Paris. So I like this way better.
Dr. Mariam,
Yes.
I think this way is better because the previous, when a person would be picked for a case, would discourage the others from participating because they would think all the questions are directed to one person, especially people who are not in the same level.
Yeah, I think it's a good way also. My initial thought was to prepare the BGY 7 or the R7 for the exam. And usually the exam is a case for you. So you should be able to answer all the question and run the case and expect to manage the complication. And this is the way we usually be trained to do this way. But if you guys find this much more fun and benefits lots of the residents, then for sure we can do this, no problem. Thank you very much for all of had participated.
Okay, thank you guys. All the best.
Thank you, Dr. Mohammed. So for today, the second 2 lecture will be postponed for next week. We'll include our session for today. Thank you.